Secretary of the Ophthalmic Research Association, Dr. R.P. Center for Ophthalmic Sciences, welcome all the delegates and speakers and the faculty members to Delhi Ophthalmological Society's monthly clinical meet being held here at Dr. R.P. Center for Ophthalmic Sciences. I invite our chief at Dr. R.P. Center, Professor J.S. Tityal, to welcome the chairpersons of the session, Dr. Rajendra Prasad, who is the Vice President of Delhi Ophthalmological Society, and Dr. J.S. Bhalla, who is the Secretary of Delhi Ophthalmological Society. Dr. Rajendra Prasad is the Vice President of the Delhi Ophthalmological Society. We welcome him to Dr. R.P. Center. Dr. J.S. Bhalla is the Secretary of the Delhi Ophthalmological Society. We welcome you, sir, on behalf of all the residents and the faculty members to Dr. R.P. Center. Thank you, sir. I now request our first speaker, Dr. Kusumita.
Thank you, Ritvik, for a nice introduction to the entire the scientific session which we are going to have today under the Delhi Ophthalmological Society monthly meeting at RP Center. We are very, very happy that in the month of June, which is the hottest month of a year, and we'll have a hottest meeting in RP Center. Very thankful to the Executive Committee of DOS, especially Dr. Bhalla, and Dr. Pawan and Dr. Rajendra Prasad for giving us this opportunity for us today to showcase the old tradition of RP Center in various monthly meetings. We have been a part of a meeting since inception of Delhi Ophthalmological Society. I'd like to welcome all of you today and welcome Dr. Rajendra Prasad and Dr. Bhalla for this meeting, and hand over the mic to Dr. Bhalla.
Dr. R.P., would you like to say? Thank you, Dr. Tityal, and it's really happy to be here, and I welcome you all to this DOS monthly clinical meeting at RP Center AIMS. And as we know that RPC clinical meeting is always an exceptional meeting because of its unique case presentation, and we have Professor Tityal to talk on a very important subject, and then along with that we have Dr. Boris Malugin. He is going to talk about one of the very important talk on the cataract surgery. So I hope this meeting is going to be very interesting and enriching in our clinical knowledge. Thank you very much. I'd request now our Secretary, Dr. Bhalla, to start the proceedings.
Yeah, without much ado, I think we'll start the clinical meeting. It's always a pleasure to be at RP Center. It's one of the most prestigious and very well organized meeting. And like we are introducing many news in our monthly meeting, and today we have one international speaker joining in the monthly meeting so that we get international flavor also in our clinical meeting. So I'll now invite the first speaker for today's case presentation. The topic is super selective intra-arterial chemotherapy for retinoblastoma, and the presenter is Dr. Kusumita, and preceptor is Professor Bhavna Chawla.
Thank you, sir. Good morning, everyone. I am here to present a case of super selective intra-arterial chemotherapy for retinoblastoma under the guidance of Professor Bhavna Chawla, ma'am. To move ahead, the history: 2-year-old child presented with informant being the father, presented with chief complaints of white reflex in both the in right eye since 3 months, and patient was taken to the local hospital wherein he was suspected to have retinoblastoma and referred to our center. Her further history, the antenatal prenatal history was uneventful. On family history showed no similar complaints in the other members of the family nor in the parents. On general physical examination, the child was a moderately built and nourished child appropriate for age with no palpable lymph nodes, with systemic examination being normal. On ocular examination, the vision in the right eye was not following light, and in left eye the child was following light. On examination under anesthesia, right eye showed mild congestion with normal corneal diameters. AC was relatively shallow with IOP being normal, and pupil showed a white reflex and lens was clear. Whereas in left eye, the anterior segment findings were within almost normal with white reflex being present and lens being clear. On posterior segment evaluation, there was a large endophytic mass with retinal detachment reaching till the posterior capsule of the lens, whereas in left eye also a similar endophytic mass was present with shallow retinal detachment at the posterior pole. This is a clinical picture which is showing the anterior, this is a clinical picture of the right eye wherein an RD, mass with an RD reaching till the posterior capsule of the lens, and the left eye there is a endophytic mass or red cam image showing endophytic mass with a shallow RD at the posterior pole. Further on investigations, ultrasound image of the posterior segment showed right eye a diffuse mass reaching till the lens with calcifications, and left eye showing a mass about 11 into 9 mm with intralesional calcification. And contrast enhanced MRI was also done, fat suppressed MRI, which showed at different sections it showed a multiple bilateral intraocular mass with remitted intraocularly with no breach in the coat, and there was no intraocular intraoptic nerve extension. Thus, the diagnosis made was right eye group E RB and left eye group D retinoblastoma as per international classification of retinoblastoma. Moving ahead to the treatment, we had started with 2 cycles of intravenous chemotherapy. The child showed no response, much response, so right eye enucleation with implant was planned, and histopathology report of the same showed no high risk characteristics, and further we continued with 4 cycles of intravenous chemotherapy with focal therapy to treat the left eye tumor. At the end of 6 cycles of chemotherapy, we noticed the left eye showed a residual active mass at the posterior pole with no much improvement with chemotherapy. So what would be the next step? So there are many options available like enucleation, EBRT, intravitreal chemotherapy, intravenous chemotherapy, and plaque brachytherapy. So let's discuss, let's give few points which are not suitable for this case. As enucleation, this child has already been bilateral RB. This is the only seeing eye with this results in irreversible loss of vision and disfigurement. Whereas in case of EBRT, though EBRT is a radiation therapy, but it can cause loss of vision because of cataract and irreversible loss of vision because of radiation retinopathy, and is also risk of secondary malignancy. Whereas intravitreal chemotherapy, there is no much role of intravitreal chemotherapy here because there is no vitreous seeds as such. Intravenous chemotherapy, as the child didn't respond much with the chemotherapy, and there is also severe toxicity with intravenous chemotherapy, it also doesn't have much role. Plaque brachytherapy, based on the location and the size of the mass, it is not suitable for plaque brachytherapy also. So the option left was the selective intra-arterial chemotherapy. So moving ahead to selective intra-arterial chemotherapy, it is a direct cannulation to the ophthalmic artery, which is a targeted chemotherapy to the eye. So how was it performed? The child was worked up for all routine blood investigations, and then the procedure was conducted under general anesthesia with intubation. As it was a left eye femoral artery was accessed, and intravenous heparin was given, and fluorescein guided the catheter was passed to advance to the aorta carotid artery and the internal carotid artery. Serial angiographies were also performed to know the proper positioning of the catheter, followed by which under root map guidance technique, the microcatheter was selectively catheterized into the ophthalmic artery, and selective angiographies were also confirmed by choroidal blush, and followed by which chemotherapy Melphilline was infused under pulse fashion over a period of 30 minutes. Repeat angiographies were also performed after the procedure to exclude the thromboembolic events. So why Melphilline was the first choice? Melphilline, being a chemotherapeutic agent, it's an alkylating agent. It has showed a greatest effect over the retinoblastoma cells by 3 different mechanisms, and although it is not used in the intravenous chemotherapeutic options because of the severe myelosuppression. So the preparation of Melphilline, the Melphilline is available commercially in 50 milligram powder form with a 10 ml diluent, which will be dissolved together to form a suspension, out of which a 0.8 ml of suspension will be taken along with normal saline to form a 30 ml solution, and this will be injected over a period of 30 minutes. So after treating the child with intra-arterial chemotherapy of a Melphilline at a dose of 4 milligram at an interval of 4 weeks, the child showed a response, the mass significantly reduced, and there was a mixed pattern of regression with calcification as well. So the REDCam image at the follow-up showed a stable regress lesion, and this was the 6 months follow-up image which showed a regress lesion, and the same at the 2-yearly follow-up it also showed a stable regress lesion. So the treatment outcome as per this case is the right eye enucleated with an healthy socket with a good prosthesis fitting and good aesthetics, and left eye was a group D RB which was regressed with some functional vision which helped the child to lead his life. And further discussion of this case will be done by Professor Bhavna Challa ma'am.
Okay, so thank you Kusumita for a very nice presentation. So I'll be briefly discussing the role of super selective intra-arterial chemotherapy for retinoblastoma cases. So as you all know, as far as retinoblastoma is concerned, it's the most common intraocular pediatric malignancy, and the goals of therapy start with saving life because it's a life-threatening situation and some children come to us pretty late at the stage of the disease. Now with so many globe salvage therapies available, we also try to save eyes of many patients, and sometimes the child is fortunate to be seen in a very early stage, as you can see in the clinical picture over here, these 2 small lesions where we can also save the vision. Over the recent years, there has been a paradigm shift from enucleation towards the use of globe salvage treatments, and as Kusumita has already illustrated, there are many globe salvage treatments available at our disposal today. Now, as far as super selective intra-arterial chemotherapy is concerned, this is basically a form of targeted chemotherapy, and there's a lot of enthusiasm all over the world because it delivers a targeted chemotherapy through the ophthalmic artery right into the eye. Now, this was a landmark paper by the Sloan Kettering Memorial Institute. Dr. Pierre Gobin and Dr. David Abramson, they first reported this technique with their experience in a cohort of retinoblastoma cases, and after that, it found a place in the treatment in many retinoblastoma centers all over the world. So, that very year, I happened to be at Wills Eye Institute, and that is where I saw my first case of intra-arterial chemotherapy being performed by the interventional neuroradiologist. So I came back and thought that why not we start this treatment at AIIMS, but we had a challenge. Obviously, we needed a multidisciplinary approach, so just ophthalmology is not enough here. We needed an interventional neuroradiology team, which was very skilled with high degree of expertise. We needed a pediatric oncology backup because these children often are on chemotherapy and some of them are very sick. So putting together a team was the challenge. But fortunately, we have Professor Shailesh Gaikwad, who is here today. He's the head of interventional neuroradiology at AIIMS, and he has supported us. And today, we are very proud to say that we have been saving many eyes and vision of many patients using selective intra-arterial chemotherapy with his support. So I will be just showing a small video. Kusumita has already described the case, but this is a short video. May I?
Yeah, yes.
Thank you. So this is how, this is a video which is recorded at the Interventional Neuroradiology Lab. The procedure is done under general anesthesia. These are the guiding catheters and the guide wire and the microcatheter that is used. So here you can see how the femoral artery puncture is done, and this microcatheter is basically, this is under fluoroscopy guidance. You can actually visualize it. So the catheter is introduced and it is going all the way up to the aorta. If you remember your anatomy, it has to reach the internal carotid artery, which is a branch of the aorta. So once it reaches the head and neck region, again under fluoroscopy guidance, you can see its position. It's actually entering into the eye. Now the challenge here is to enter the ophthalmic artery, and if you remember, these are very, very young children. So, it requires a very high degree of technical skill and expertise to get into the ostium of the ophthalmic artery to be able to deliver the chemotherapeutic drug in a targeted fashion. So here you can see that, the ostium, and this is basically a dye is being injected to see the anatomy and the vasculature, because sometimes there is an anomalous circulation, and the eye may be supplied by the middle meningeal artery, which is a branch of the external carotid. So all those things have to be confirmed. So luckily in this patient, it is the ophthalmic artery. You can see over here, this is a takeoff from the internal carotid. And again, you can see over here the microcatheter going into the ostium of the ophthalmic artery so that targeted drug delivery can take place. So So it has entered, and this is again to confirm with the dye. You can see the choroidal blush, which is the vasculature to the eye. The Melphilline injection has to be prepared freshly at that point in time when the procedure is being done. And as Kusumita explained, it's over a period of 30 minutes. It has to be given in a slow pulsatile fashion. So important considerations, again, a multidisciplinary team, as I have already emphasized, and careful case selection. Not every child with retinoblastoma can benefit from this treatment. So there is a checklist for exclusion, and we must carefully follow that. Still, despite that, with the best of case selection and the best of technique and expertise, there can be certain complications that we must be ready for, and they can be anesthesia related, or they can be local, or they can be thromboembolic phenomena. So we need to have a setup ready to be able to manage these complications if they occur. But in the hands of our interventional neuroradiologist team, these complications are very, very rare. This is one such case who developed a transient third nerve palsy after IC. After 3 weeks, it recovered. Failure of cannulation, obviously it is very challenging to cannulate ophthalmic arteries for such young children. They can be small size, there can be vasospasm, there can be steep takeoff. Sometimes we have to abandon this procedure, sometimes we have to take the external carotid route. So this is an article where you can read more about this procedure. I thank you all for your attention, and I would invite Professor Gaikwad, who is here with us today, for his comments. Thank you.
Yeah. We are privileged to have Dr. Shailesh Gaikwad, who's an intervention neuroradiologist, and we request him to give his comments on this case.
At the outset, I wish to thank the Delhi Ophthalmic Society for inviting me here in this August forum. It's a great honor. Thank you, Dr. Bhavna, Dr. Tityal, and the entire team. So, as Bhavna has told everything, the journey began almost 10 years back. And over the years, we have learned this technique. Let me tell you, ophthalmic artery is the first branch of internal carotid artery. Sometimes, when you don't intend, it enters the microcatheter. But when you are really intending to go into the ophthalmic, it will fail to go inside. So these are sometimes the challenges. We have seen anomalous origin from the external carotid artery also in some of the cases. So when we fail to go through the internal carotid, we always take a shoot through the external carotid. And retrogradely, you will see some of the branches are going, usually the ethmoidal branches. They reconstitute the ophthalmic artery. So from there, if you see a choroidal blush, the tumor blush, then sometimes we have gone into the external carotid artery and given the chemotherapeutic drug. So I think this case is a very good case. I think exemplary, 2-year-old child. In a smaller kid, the orifice is usually very small, and entering sometimes this artery is usually challenging. So you require a little bit of efforts and patience, of course, but we do succeed most of the time. So if there are any questions directly addressed to me on this particular topic or technique, most welcome.
So,
Thank you. A really nice presentation. I have just one query. When you are injecting the drug into the ophthalmic artery, is there any chances of drug flowing back and going into the carotid artery?
We take a shoot once we navigate the ophthalmic artery and look for the reflux. So that reflux is very important for us. When we inject fast, the reflex will generally happen. So we don't inject very fast, we inject very slowly because our injection rate is 1 ml per minute. So when you are injecting very slowly, the reflex doesn't happen.
And how do you ensure that drug stays in the ophthalmic artery or in the tumor? When you remove the catheter, it doesn't come back and go into the circulation?
At the end of the infusion, we generally infuse the microcatheter with the saline.
You plug it?
We don't plug it, but we infuse the microcatheter with the saline chase so that the entire dead space is emptied with the saline.
All right.
And literature also mentions that you do, sometimes you're required to do balloon occlusion at the origin of the ophthalmic artery from the internal carotid artery so that it does not go distally into the circulation.
So when you are very close to the ophthalmic artery origin, reflux may happen, but if you go a little more distally, reflux won't happen. And putting a balloon means requiring additional maneuver. The child is very small, the artery is very small, you take another balloon, means you need 2 accesses, right? So one for the balloon system, one for the microcatheter system, you inflate the balloon. So where are you inflating? You are inflating across the ostium of the ophthalmic artery. That is the bony segment of the artery. When you inflate, you impinge on the intima of the artery. So there is every chance that you may dissect the artery. So in order to avoid that, we go a little more distal to the ophthalmic artery origin.
And suppose there's no response to intra-arterial Melphilline which has been used. Other agents which can be used because...
I think Dr. Bhavna will tell you that. We can use 3 drugs more, 2 more additional drugs. So sometimes we are given a combination of 3 drugs in one single patient. And sometimes you need to repeat the cycles.
Right. Thank you, sir. Thank you. Any question from the audience? House? Any query?
If you don't have a femoral artery access, then you can go to the radial artery. But if you have a femoral artery access, I think the femoral artery access is the best because when you go to the radial artery, you are very close to the image intensifier, the fluoroscopy unit. That means the operator is getting a radiation dose. So every technique has advantage, every technique has disadvantage. You have to choose what is best for the patient and for the operator. In a busy department like AIMS, when you are doing intervention left and right? So you have to play a very safe role because safety in a long term is also important.
Thank you, sir.
Thank you, sir. Thank you.
Thank you very much.
We come to the second case. The case 2 is bilateral rapidly progressing retinopathy of prematurity, and this is to be presented by Dr. Nawaz Sheikh. Preceptor is Professor Parijat Chandra. I think I'll request to please stick to the time because that also overshooting the time, the marks are deducted.
Good morning, everyone. Respected faculty members and my dear colleagues, I'm Dr. Nawaz Sheikh and I'll be presenting on bilateral rapidly progressive ROP under the aegis of Professor Parijat Chandra. So the child presented with a gestational age of 29 weeks with a birth weight of 1320 grams at a post-conceptional age of 33 weeks with risk factors of respiratory distress, sepsis, jaundice and poor weight gain. He was referred from a private clinic in Delhi for our second opinion. At presentation, the child had zone 1 stage 3 ROP with severe plus disease as evidenced by the dilated and tortuous vessels at the posterior pole. We went ahead and advised both eye anti-VEGF injection. However, the referring surgeon went ahead and performed a laser and then referred the child again to us at 2 weeks with rapidly progressive ROP as evidenced by the rapid progression of tractional RD in the periphery as shown by the blue arrows. At this point, we went ahead and advised a both-eye lens-sparing vitrectomy with injection Lucentis under general anesthesia in the same setting for both eyes. So this is a video showing lens-sparing vitrectomy using 25 gauge system. Core vitrectomy is done. We go ahead and remove the traction in the periphery. PVD is induced, especially at the posterior pole. So we can see the extensive neovascularization present. So this was the point where we decided that injection Lucentis has to be given after fluid air exchange. And we can see injection Lucentis being injected right now. And we had a sutureless closure at the end of surgery. So at 3 weeks post-surgery, what we noticed was that there was some amount of pre-retinal hemorrhage, but the tractional retinal detachment had resolved. At 12 weeks post-surgery, there was complete resolution of not just the tractional retinal detachment, but the pre-retinal bleed, as well as there was vascularization up to the laser marks. Further discussion and learning points will be talked about by Professor Parijat Chandra.
Thank you, Dr. Nawazish, for the excellent presentation. So I'll be talking about some of the learning points which we can take away from this case. So she's talking about zone 1 ROP. Is this aggressive ROP? Aggressive ROP or AP ROP is a very severe variant of this disease. So if you look at the left side, this was what our case was, and aggressive ROP is what typically looks like in the right photograph. So both are zone 1 disease. Why is it zone 1? Because it's twice the disc macular distance. So you see the yellow circle there. This was a case of zone 1. Although temporally it progressed into zone 2, but we take the lowest zone to consider the severity of the disease. So this is zone 1, but you can see it's got a very classical ridge which is there, which was not there if you see a case of aggressive ROP where it's just a bunch of loops and with plus disease, and you really don't know where the junction is. So typically they both behave in a similar manner, although AP ROP can behave in a more severe manner, but considering that a large amount of ischemic area is left, the stimulus is enough to provide a rapidly progressive disease. So in zone 1 ROP, should we give laser or anti-VEGF? So as she informed that initially we had advised anti-VEGF in this case, but for logistical reasons maybe the practitioner went ahead with laser. So although the laser was very nicely done, the disease continued to progress despite the excellent laser which was performed. So we need to understand that zone 1 ROP progresses very fast because a large amount of ischemic retina is there. And laser has a slow action, though it is sustained, but it's a slow action and the response can be unpredictable in zone 1 ROP. Moreover, if you go ahead and laser like 80% of the retina in zone 1 ROP, then the patient will have limited visual field. He'll have high refractive errors coming because of extensive laser. And the bigger problem is that it will be a very long procedure because the pupil will not dilate. He's got severe plus disease. It's a small rigid pupil. It will take hours to just laser the entire retina, or you will just leave large amount of skip areas behind. You'll have to laser a large amount of retina, 5,000 spots, 7,000 spots going into each eye, and the child is going to have severe pain, which is well documented now in literature, and is going to lead to an unstable kind of baby, which probably will not allow you to complete the procedure if you're going to take 3 hours to complete this laser in both the eyes. So better option here would be to do an anti-VEGF injection, which is much faster. It will be more predictable. It will allow you to give a rapid disease regression, which is exactly what we want. It will allow rapid revascularization as well over the next few weeks, which will allow the field to develop and the child to see much better than what it was before. And it will be a shorter procedure. You just have to inject. It's just a 5-minute procedure, and you will have a much more stable baby in these scenarios. Now, when should you operate this case? So you see we operated the case very early, within 2 weeks once it started to progress. So we need to understand that the RD configuration changes as the disease progresses. So initially it's just a thin structure where you can just do a very quick traction relief as she showed in the video. It's got less neovascularization, so there will be less intraoperative bleeding, less postoperative bleeding, and obviously the TRD is less peripheral. So it's easy to access, the instruments can go in easily, otherwise you might end up with a subretinal injury. And then obviously it's got a low height. So that is the best part because you can do an easy lens sparing procedure. If it's just stuck behind the lens, then it's very difficult to do a lens sparing procedure. You will end up with lens injury. And if the macula is spared, then you can have a very good outcome with these surgical scenarios. Another thing which you notice in this case was we did a bilateral surgery in a single session. So we are very cautious not to do bilateral surgery in different ophthalmic diseases with the risk of endophthalmitis and other problems. So this is possibly one of the few rare indications of ophthalmology where we want to do bilateral surgery in the same session. I mean, what are you waiting for? Both the eyes, the patient is going to go blind, and if you keep on waiting, do one eye and then wait for the other eye, then possibly the child might become sick after GA and he might not come for the other eye, and one eye might go blind. So immediate sequential bilateral vitreoretinal surgery is the way to go. It allows timely management in both the eyes with progressive stage 4 ROP, and it gives a single exposure to high risk GA. So intubation extubation is the most risky part in a sick preterm baby, and many children get stuck in that part, or they might not come out of table with severe problems. So it's obviously best to have as less exposure to high risk GA as possible, because the parents give high risk consent for these procedures. The NICU backup is there, the surgical backup is there. So there are a lot of problems. But what you need to take care in these cases is you have to treat the second eye as an independent surgery, which means you need to rewash again, the team needs to rewash, you need to change the instrument, you need to change the fluids. Then you go in as a fresh case in this eye in the same sitting. And obviously parent counseling and informed consent is very important, because they should be clear why you are doing it in the same sitting. God forbid if something goes wrong and they don't know why you are doing it in the same sitting, then that's not the right way to go about it. Another thing you notice special in this case was the combined anti-VEGF with vitrectomy. So if you see, this is the kind of outcome. You see, if you operate an eye of stage 4 ROP, there will be remnants, because basically what you are doing is removing the traction. You can't deal with the RD. You are removing the traction and the TRD falls back. So there will be a lot of remnants in stage 4 ROP which will be there. But you see here there are no remnants. It's almost as if the TRD never happened. So this kind of magic can only happen if you combine surgery with anti-VEGF drugs. If you do it alone with surgery, then this kind of results cannot be obtained. So I'm not saying do it in all cases, but in selected cases it works very well. So why does it work so well? So you see, vitrectomy takes care of the traction relief on the TRD, it takes care of the centripetal traction, it takes care of the circumferential traction, it takes care of the vertical traction. If you do localized PVD, the macular traction is relieved from the peripheral TRD. It acts like an abscess drainage. You remove all the inflammatory factors, you remove all the VEGF, so the disease regresses faster. If there's a big chunk of TRD, a big chunk of area where it's very vascular, you can cut off the blood supply by cauterizing the feeder vessels, and it takes care of all those vessels. Then the vitreous hemorrhage can be drained, preretinal hemorrhage can be removed by doing the PVD in that local area. So a lot of things can be taken care of with vitrectomy alone. But why add anti-VEGF? Anti-VEGF helps in rapid VEGF neutralization of whatever is left, because you can't do a complete vitrectomy and the factors are constantly being released. It's not a one-time process. There's rapid neovascularization regression, which is I think one of the major factors which helps in taking the thickness out of the ridge and allowing to settle very fast. And this not only helps to take care of that, it reduces the intraoperative and the post-operative bleeding as well, which is a major problem in these cases which are very vascular with TRD. And this whole process then allows for rapid ROP regression. So you see, vitrectomy is not allowing for rapid ROP regression, but anti-VEGF will allow for rapid ROP regression because of all these features. And if you combine best of both, then it's going to really come down very fast. So in conclusion, had this case come to us in the first go, how would it have been managed? So this is the line of approach which we follow for zone 1 ROP or aggressive ROP management. So anti-VEGF would have been the first line of treatment in zone 1 ROP, and then we have to let it grow. So it's a common mistake that once you inject and in a few days, 5 days, 7 days, people go in and do the laser. So give it time, it works very well for the next 6 to 8 weeks. Let the retina grow so that the child has fees. After all, that is why you gave the injection. You wanted rapid regression, you wanted revascularization. Let it grow, and once it reactivates, which it commonly does in 60 to 80% of cases, especially with Lucentis which we are giving. So then you can go ahead and either laser this eye for the peripheral avascular retina, or you can give another injection if you want it to grow further. And then if it doesn't reactivate and continues, then possibly you might have a peripheral avascular retina. If it's significant, then it's more than 12 weeks, then you can go ahead and possibly laser that area which is avascular, because later it might develop lattices, holes, is a thin retina. And future you don't want it to develop a GRT or something like that because of the avascular retina. So that's how the approach is. So I hope we learned from this case, and you picked up some good learning points which will help you manage the next case of zone 1 ROP. Thank you so much.
Thank you very much. Thank you, Dr. Parijat, for the nice discussion. What I understand with your presentation is in the AP-ROP, the most important point is the early diagnosis.
Yes, sir.
So at what stage, because general concept is to look for the ROP at the age of 4 or 5 weeks of age. So what should be done in this situation, like if you have an AP-ROP? Yes, sir.
So the RBSK guidelines, which are now the national ROP guidelines, are there. So they recommend that if the child is less than 28 weeks and less than 1200 grams, then we should screen these babies as early as 2 to 3 weeks. If it's bigger than that, then we can screen at 4 weeks of life. And basically this is there to pick up the aggressive ROP. So if the child is less than 28 weeks, less than 1200 grams, better to go ahead and screen early. And if we pick it up in time, then we can go ahead and do an early treatment.
Right. So this is very important actually, because we generally have a concept to look for the ROP at the age of 4 weeks. But what I think is it's very important immediately after the birth, even a week or 2 weeks is very important for AP-ROP, because if you diagnose early, then you can treat because very well managed. If you leave it, if you try to find it out at the 4 weeks, then I think everything will be
Yes, sir.
gone by that time.
Yes, sir.
Thank you very much. Thank you.
Yes, Dr. Parichat, very nice case. Normally it is said that aggressive posterior ROP progresses in spite of having tried all modalities of treatment, but this was very nicely managed with simultaneous anti-VEGF injection and bilateral vitrectomy surgery. Any systemic factors which you could evaluate for the cause of this APROP, like they say multiple infections and thrombocytopenia is one of, these are some of the causative risk factors?
Yes, so mostly aggressive ROP happens only in situations where poor NICU practices are there. So if a good NICU practice, aggressive ROP we will not see. So like just for example, in the last 20 years in the AIMS NICU program, we have never seen a case of aggressive ROP. Whereas in the outborn babies which come to RP center, we see around 2 to 3 every week coming to RP center. So it's all because of poor NICU practices which have a lot of risk factors which are not properly managed. They give 100% oxygen, things like that, which lead to these kind of problems, sir. So the others.
Right, sir. Thank you.
Thank you, sir.
And now we have the, I think, guest presentation. This is our attraction. So now we have, before the guest case presentation, we have clinical talk by Professor Jeevan Sthityal, and he's going to talk on toric IOLs, maximizing outcomes.
Good morning, friends, and like to welcome all of you and thank you all the DOS members coming for this monthly meeting today in RP Center. And we had a beautiful case presentations, unique ones, which are very, very difficult to manage. But we all know cataract surgery is bread and bread for everybody, not only for our practitioners, for our people serving the government, and people have to do cataract surgery. And we know that there has been a huge increase in the load of toric IOL implantation in last few decades. We have understood the technology, we have a better intraocular lens designs, and understanding from patient point of view has also improved. The actual implantation IOL percentage has increased so much. There are three important things to be considered in these cases when actually we are going for a toric implantation. That is, the patient selection has to be perfect. Second is the biometry, and third is the appropriate IOL power calculation for that particular case. Just see the scenario here. If you have one patient coming for you for a routine surgery of monofocal IOL. If you see here, if you do a biometry, the toric calculation is 2.4 diopter. So this is a range higher than the normal accepted toricity of cornea, around 1.25 diopters. The most suitable option will be cataract, along with the cataract surgery, the toric intraocular lens implantation, rather than doing other procedures, which may be, people talk about surface ablation sometimes, or talk about keratotomies, which may not be as predictable as intraocular lenses. But you have a scenario where you have a very less cylinder. You can see here it is just 0.31 cylinder. There's something wrong with the, my pointer. So if you have this patient who only has 0.31 diopter, this patient is suitable for all types of IOL, which may be multifocal, monofocal, and very good case. So in looking into a corneal toricity will give you an assessment of your patient what type of IOL going to choose in these cases. But you have a cases of premium IOL where the toricity, you can say threshold is very, very less as compared to monofocal lenses. Even you have a less than one diopter cylinder in the cornea, you may have to go for toric IOLs, multifocal toric IOL in these cases. So that is the basic concept or indication of a toric implantation of these patients. Selection wise, patients should be well aware of a requirement of his or her own daily work. Sometimes people do require correction of a high cylinder, which gives you a less dependence to glasses also. So you require to do a comprehensive examination, rule out all those factors which may be compounding to give you a very poor outcome in these patients. Therefore, the biometry is very important. Axial length measurement has to be as accurate as possible. So optical biometers will be a good choice. But if you don't have access to that, you can always go for immersion ultrasound biometry, which is a gold standard for many, many years. Then keratometric assessment should be done, which looks into two important aspects: the power, that is amount of cylinder in the cornea, and its axis, which can be measured by at least two measurements by two different equipments. We should have a very good alignment in terms of amount of cylinder and the axis. If these two are equally matching in the two investigation, that's a good case for your assessment for this particular case. To make sure you have enhanced accuracy of your biometry, so if you have devices where you have OCT based attachment, which will give you analysis of entire axial length and curvature of cornea, anterior and posterior. Just give you this example, you can say this scan has gone parafoveally, therefore it is not centered well. So it is a paracentral. So this is going to give you a high cylinder, like in this case a 2 diopter. You are falsely going for toric IOL in this patient. But if you correctly analyze this particular case here now, it is a foveal centration passing through the scan right from the fovea and no cylinder here. So this gives an example that your assessment has to be absolutely accurate in this patient. Ocular surface disease like this, where you have a scan little poorer, this can be because of various reasons. It may be because you have done an investigation before you have done a biometry, which normally we do it. You have dilated the eye, you have done a fluorescein examination. Always do a keratometry assessment as a first investigation for a premium IOL investigation. That is one important thing to learn for us. So this patient, after we put a lubricant, very nice assessment of her rings, and we didn't have a cylinder in this patient, you could do without any surgery. Anything which can increase the toricity, like a pterygium, will have to be giving distorted bias, and your keratometry reading may not be appropriate. So this patient will put the lubricant, and you had a very good reading coming out subsequently in this particular case. So this patient would require a pterygium assessment first, because the cylinder is quite high as such. You can see the cylinder in this particular case was around 7 diopter despite putting lubricant. So you have to do a pterygium surgery first, wait for 6 weeks, then do a surgery in this particular case. Peripheral opacity in the cornea can also give you a cylinder. So this patient has a 1.3 diopter cylinder and axis 163. We did another assessment with eye trace, give a similar degree of amount of cylinder as well as axis. So this patient will definitely benefit with the surgery despite having a larger degree of higher order aberration also. So you have to look into amount of cylinder and axis in a difficult cases also. This particular case, you can see a large pterygium, which is not going to give you a good reading. Again, the learning here is treat the ocular surface first, then go for all these important areas. Biometry wise, you can look into other parameters also. Both internal aberrations should be seen in these cases apart from corneal aberration, which is very, very important aspect. If you have a poor corneal aberration, not fit for any surgery in terms of premium IOL. Then you have little bit on a posterior corneal astigmatism. We all know the anterior part acts like a spherical lens, which can be with the rule, against the rule, oblique, which changes with time towards the against the rule in a life. While the posterior astigmatism is always against the rule, which is around 0.3 to 0.5 diopters and remains throughout the life similar. So this has a huge importance in those cases where you're going for premium IOL. So if you only consider anterior part of a corneal cylinder, if patient has a with the rule astigmatism, you're going to overcorrect. If patient is against the rule astigmatism, you're going to undercorrect these patients. So just to give you one IOL master example here, you can see if you just see the total keratometry 1.18 diopters. But see the anterior one is 0.89. So if you just take 0.89, you're going to give a lesser degree of astigmatic correction in these patients. Therefore, instrumentation which can give you a posterior corneal curvature analysis would be a good way to look into. So this patient, in fact, T3 may not give you a good result, 0.55 diopters. If I go for T4, which is going to 0.02 diopter, which is a suitable IOL for this particular patient. So just to summarize the importance of posterior corneal astigmatism, as I told you before, anterior corneal surface always behaves like a plus lens, which can be with the rule, against the rule, or oblique, changes with time towards against the rule. Therefore, many patients coming for cataract age will have against the rule astigmatism. Posterior corneal surface is always against the rule. Just see here, if anterior curvature with the rule, we know the posterior is always against the rule, and ultimately you are going to overcorrect if you just consider anterior surface only. If patient has both anterior and posterior against the rule, you are going to undercorrect these cases. So this is a significant important part. Just to summarize the first segment of my talk, when to implant toric IOL, if they have a regular astigmatism, around 1 to 1.5 diopter or more should be taken into consideration. Multifocal, even up to 0.75, you have to go toric lenses. Look for a magnitude and axis will be matching with the various investigations. And look for those IOL power formulas which takes into consideration posterior corneal curvature, surgically induced astigmatism, anterior chamber depth, and effective lens position. If all these parameters are there in that formula, that would be a good formula to be considered for a premium IOL, including toric lenses. The second aspect is a surgical approach, how to align these lenses appropriately. For that, you need to know the steeper axis of a corneal cylinder, mark the axis, reference axis in the eye, then do a proper implantation of the axis of your concern. You can do a manual marking, you can do image-guided surgeries, or you can have access to a intraoperative aberrometry, which can give you a good align for these cases. Just to show you one video here, incision has to be always in a one position. Never change your incision as per the cylindrical axis. Therefore, you will have a good analysis of SIA for your patients. Do a rhexis, which is going to cover the entire surface of IOL in the periphery around 0.3 to 0.5 millimeter. This should be well centered in the area of concern so that your lens remains in the bag appropriately. Phaco should be done in a right manner to safeguard the capsular axis margin as well as the posterior capsule so that you can implant the lenses in a proper position here. So once we do a proper aspiration of cortex complex, the posterior capsule can be cleaned up, anterior capsular margin can also be polished. Make sure you remove the viscoelastic both from the anterior part of the lens and from the posterior part of the lens so the entire bag is absolutely deprived of viscoelastic because that may be a cause for rotation subsequently. Keep the lens in the desired axis, at least little bit anti-clockwise so you can rotate these lenses clockwise. So this is the end of surgery you can see here, effectively done as such. But sometimes you can have little bit of problem, especially when you have to keep the lens in a vertical orientations. There lens movement can be there, especially if the lens is not open effectively. Therefore, the viscoelastic removal has to be much more thorough, give time for a assessment. I thought I had kept the lens in the proper position here. When I hydrate the wound area, the lens is shifted clockwise. So you can't rotate this lens backwards. So you have to rotate entire 180 degree to make sure whenever you have a vertical orientation, keep the lens little anti-clockwise so you can manage these lenses subsequently by tucking them in a proper position. Just to see if manual markings are equally helpful, once you have a 3 reference marking, then I'll use the bimanual technique of toric orientation and put a radial mark which is concerning the axis. Most importantly, the mark has to be absolutely sharp and clean so that you are well oriented. If you have a fuzzy margin, then difficult to have an analysis done appropriately. So both manual and as well as image guided can be done. And looking to results wise, if you compare both, it's not much different in terms of visual acuity wise. But you can see here, image guided will give around 3.7 and the manual gives around 0.5 degree away from the desired axis. Not significant as such. Acuity wise is normal, but if you look into visual quality, let's say the rotation from the main axis, you'll have better visual quality as such, which is true with the image guided ones. Summarizing this particular segment of my talk, always if you have manual, pendular markings are better. Image guided system will give you better outcomes visual quality wise. Access to intraoperative aberrometry may refine your cases in a difficult cases like a post-RK or post-refractive surgery patients. These are some difficult scenario might come during your surgery wise. Small pupil, you can always see these cases can give you a difficulty in any stroke surgery. Make sure your initial analysis of pupil is better. It should be dilated with intraoperative mediatic solutions. Do a phaco in a very, very low parameter so that your pupillary margin doesn't get flutter. You manage the pupil appropriately. Then complete the surgery. Remove your cortex, then implant the IOL. Make sure at least 3 marks are visible before you remove the viscoelastic from underneath the lens. Rotate the lens to a desired axis to begin with. So I have the axis mark visible, I'll rotate it. You can see at least I can see this particular area, not visible this side. So this gives you a satisfactory implantation of toric IOL. If it is smaller than that, not visible marks, then you may have to use iris hooks in these cases also. So this is a post-RK patient where you can still do a toric lenses if you have a good aberrometry profile of a cornea. The only thing I want to highlight here is once you complete the surgery, These cases, implant the IOL in axis and always put a little bit of suture. One suture will give you a good, you can say, a position of wound. If you hydrate, then these wounds can, either get entire incision hydrated and post-op cylinder may be unstable in these cases. So suture is mandatory in these cases to see. So this is one case of similar RK patient. I was doing a appropriate surgery, but subsequently I realized there was a little bit of a nick in the capsular rexal margin at around 11 o'clock position during my aspiration of vitreous of cortex here. So what to do at this stage? I'll be putting a viscoelastic on side port, implant the lens, put suture, and rotate the lens subsequently after closing the main wound, so that lens diaphragm doesn't move after you try to manipulate these cases. So when you have a rexus tear, make sure the chamber doesn't get sudden collapse happening in these cases. So this is one case, femtosecond laser surgery being done, assisted cataract surgery, which is, I think, better suited for all lenses where you require a premium IOL implantation, because your bag orientation will be better. I was doing an aspiration, left this little bit of cortex, some incisional area, implanting axis of panoptic toric lens. When I was removing this particular part of cortex, the entire capsule got torn here. You can see a large tear happening going across. What to do at this stage now? You have a trifocal toric lens inside. So I'm putting a dispersive viscoelastic underneath the IOL so that vitreous will be tamponade here. Then again put dispersive viscoelastic from this side also. So I'm making a cushion of a dispersive viscoelastic underneath the IOL. The idea here is to anterior capture the this optic of IOL, because you can see the axis is rightly placed here. The little bit of a dispersive cushion will give you a assessment. Now with this maneuver, I'll get the optic up onto the rexus margin, this inferior side, put a cushion here, then I'll shift to this side and get this lens up from the rexus also. So this step has to be done very, very meticulously without disrupting the underneath surface. With this side port, I'll get the lens up here. So this is only possible if you have a good dispersive viscoelastic which maintains the space without coming out as a bolus. So this is a bimanual technique. Now both optics will be lifted up to the rexus margin, and you can see towards the end the entire lens will be captured. I will hydrate the area, leave the dispersive viscoelastic inside, which will be taken care of subsequently. You can see this is the quadrantic shape. The optic is up here and the haptic is behind here, and it's almost at the axis of implantation. So luckily when the rupture happened, my lens was positioned the same fashion here. So this is the immediate post-op period. After 1 week, lens is stable, and so some cases you can manage with the capture in these cases. I'll take 1 more minute for a post-op analysis, which is very important in these cases. The rotation requirement is very, very less. In my experience, around 2,000 cases, less than 0.2. That too because of a mistake in orientation of these lenses. So which are those lenses which is going to be suitable for rotation? I think this is a very important slide people have to understand. Will the IOL rotation help in your cases? So if you have a spherical equivalent, more than cylindrical error, so may not be helpful for a rotation in these cases. But if your cylindrical error is more than spherical equivalent, then this particular case will have a benefit for rotation. So just see this example here. A patient has a post-op refraction minus 2.5 sphere with 1 diopter cylinder. The spherical equivalent is 2 diopters. So this patient, the cylinder is less than a spherical equivalent, may not be helpful in rotation. But this particular case, the spherical equivalent is less than cylinder. So this is the patient going to helpful in a rotation wise. So these are the 3 things required. You have to do a post-op refraction, keratometric astigmatism, and the IOL power at the corneal plane will decide if your lens is going to be suitable or not. So this is one example here. Posterior refractive error -1 sphere and 3 diopter cylinder. You have a larger component of cylinder, and the keratometric astigmatism is 2 diopter now. So this difference of 1 diopter can never be corrected because the IOL power is not as per the corneal cylinder here, but the remaining power can be corrected by rotation here. So you know how much rotation required based on your dilatation of pupil. See the new orientation of IOL away from a main axis. Accordingly, you can put into a astigmaticfix.com, which gives you analysis. You have to feed your parameters, the previous axis, new axis, the refraction power, and tells you how much rotation is required. And same thing can be confirmed with eye trace also. Similar parameters, which gives you a refraction, degree of rotation required, and amount of cylinder, could be corrected, and what will be a post-op refraction in these cases. So simply you can rotate without entering viscoelastic in these cases, and with a bimanual technique you can rotate the lens with the irrigation aspiration system only. So post-op analysis is also important. Like this was a case, had a good vision, 6/9. The refraction is 0.25. A patient is not very happy because patient has a high spherical aberration, high order aberration because of maybe because of tilt, or maybe because of cornea had aberrated beforehand also. To summarize, rotation is required in a very few cases, which may be because of a poor vision or an IOL is not properly placed, and decision has to be taken by the amount of refractive error a patient has in subsequently. People can read or review article and you can have better knowledge. Thank you for kind listening. There was something wrong, my slides are moving itself, you know. I had a difficult time to control this toricity.
Thank you very much, Professor Titial, for the excellent presentation. And we actually have given a detailed about the toric IOLs. Dr. Titial, we showed one video on the small pupil and aligning the IOL, because if you lost the marks on the IOL and you are not able to see the IOL mark, many times it happens if people goes down. There is an instrument devised by Sri Ganesh that is called as an IOL marker. What about that?
That is a very difficult part to understand, because whatever mark you put in IOL, sometimes it goes off. So you have to have a very, you can say solid mark on the IOL to see that up to the end of your surgery. So I have tried, in some cases I didn't succeed in that. So it's a very, maybe a good idea, but sometimes if you put such a strong mark, it may remain there and cause problem. Better would be use a second instrument, retract your pupil and see if your the toric marks are not correctly positioned or not. Or sometimes if you have a very small pupil, which happens in a floppy iris syndrome, you might put two iris hooks in the area of your steeper axis, then you'll know where exactly your lenses are there, because sometimes the lens may not be in the bag also in a small pupil. So that is a very important aspect. But that device, I don't know, I'm not used myself. I tried with some other devices to put a mark onto the IOL. I didn't succeed in that.
Right. And my second query is, like you said, one diopter of cylinder, especially in less than one diopter, especially with the toric, with the multifocal or trifocal or EDOF IOLs. But many of these IOLs, they say like, don't go for the toric if you have a up to one diopter of toricity, because these IOLs have the capability to control at least 0.75 diopter of the astigmatism. So what do you say about it?
I think it is important if you have around 0.75 or bigger, that is 0.8, 0.9, then I think you should go for a toric lenses. If it's less than that, yes, because it does help you in a little bit of a stereopsis happening in these cases with the cylinder, if it is with against the rule cylinder in these cases. So that is helpful. That's why many monofocal cases we leave to want to leave some sort of a cylinder in these cases. Holds true for a multifocal lenses also, especially if they have a extended range of vision type of IOLs, which has a capacity to little bit of more threshold for managing a little bit of cylinder in these cases. So if you're using extended range of vision, yes. But if you're using a diffractive type of designs, there you have to take care of entire astigmatism if possible.
Right. Thank you. Thank you.
Any questions, any comments from anyone?
I think it depends which kind of script you're reading. If you're reading from left to right or right to left. So with the rule and against the rule astigmatism, I think it's better to have a with the rule astigmatism of 0.5. And even if you've done a toric IOL, you never get the entire zero post-op retinoscopy. Patient will still have some retinoscopy. They will not accept it, but if you do a retinoscopy, you'll always have a cylinder. Right. So what you want to say something about that?
That's absolutely correct, because I couldn't cover entire thing in this talk. The first counseling which we do for these toric implantation is to the patient is we are not going to totally take away the toric refraction for your case. They're bound to have some degree of toricity, and most importantly, you might induce a toricity from your side also. Your wound may not be well managed. There may be edema in the wound area. You may distort the wound because of high power, or there may be cases where you have a wound side detachment, all those things can take away the corneal toricity significance in your cases. So you have to analyze your patient appropriately. If they have a higher degree of cylinder, let's suppose my patient has a more than 2.5 degree diopters or corneal cylinder, so those are good cases for a cylindrical power with the toric lenses, because they're going to accept a little bit of residual cylinder also. But as Dr. Rajendra Prasad says, if you have a patient with a 0.75, 0.8 or 1 diopter cylinder, the amount of residual cylinder may be 0.37, but that's a significant residual cylinder in these cases. So that point has to be assessed with the patient, and these are patients may not be happy with a little bit of residual cylinder also. And the rotation of these lenses also may not make a huge difference in terms of amount of cylinder, but visual acuity might change significantly in these cases.
But quite often we have seen, especially with the trifocal and edophiles, even if you are left with the 0.5, 0.75 diopter, the patient doesn't accept. They are happy without that cylinder, because this is my experience, because I've seen many of the guys, I don't know what
yeah, that's true. Like the experience we have with most lenses, that's why if you see my series, I have not rotated any IOL till date because my axis were deviated so much. Whichever rotation I have done is because of some miscommunication between my assistant and myself, that those lenses need to be rotated. That indicates that whatever we do in these patients, the acceptance is much better than what we think. Even you have a 6-degree rotation, the visual acuity may still be satisfactory in these cases. And the tolerance in the Indian scenario is much more than a Western scenario. In Western scenario, they do resurgery as soon as possible. Even though they have a 5-degree rotation, they might convince the patient for resurgery in these cases. And they do a OPD basis also. I have seen people doing a slit lamp, and with the needle they rotate the lens. And that is because the rotation requirement is hardly 5 degree or 6 degree in those cases, which is not true in our cases. Many patients do have a very good acceptance and tolerance of a cylinder, because that's going to give a little bit of better near vision in these cases, which is, I think, the better way to look into.
Yeah. In fact, the rotation is not that easy. You sometimes can have dialysis, everything. So you have to have two needle procedure. When you rotate with one hand, normally you're pushing the lens, it comes back.
Yeah,
so
that's right.
Actually, to have a rotation, you need to have two axes, 2 points to rotate. Yeah. So I don't think OPD thing should.
People have described that. I've seen few videos where people have used 28 gauge needle from a side port and tucked the lens and rotated those in the OPD. Because in Western area, to take the patient to OR again is a huge cost. So resurgery means the same cost of primary surgery. So all these people are looking for a simple way to handle.
Many times you could have the capsular deformity also, because misalignment, and you rotate it after the surgery, the lens comes back to that same position. This I have seen in 2-3 cases.
Yeah, that is true, especially in those cases where your bag is too big as in relation to IOL. In our very high myopic patients, or your bag is loose, or a little bit of a general weakness happening in these patients. There it is very difficult. Sometimes you may have to wait for 3 or 4 weeks in these cases, let the bag get a little shrunken with the fibrosis, then try to rotate these lenses. Maybe you'll succeed. Or maybe you can put a CTR in these cases to make lens stretched in most cases. Anything which is requires a rotation, don't jump within a day or so. Wait for a few days, let the wound settle down, get a normal corneal curvature, then plan. Nothing going to happen within 1 week to 10 days in these cases.
I think that was very...
Just a minute. Doctor, good morning.
Good morning,
you
sir.
Just told that this is possible in the OPD procedure.
Not in Indian scenario.
Not in Indian scenario, even in the Western scenario, because it's intraoperative procedure. There is something, I don't know.
No, it is not actually suitable in our scenario. We don't give intravitreal injections also, which is an OPD procedure in our Western countries. So not for our country at all.
But sitting on the slit lamp and doing this procedure?
Yeah, people have done. I've seen one video, one surgeon has submitted. He's done a phaco surgery in a patient sitting in a slit lamp.
Okay.
Yeah, I think that was very nice and exhaustive presentation.
Thank you.
I think this will require much more time seeing the importance of the topic. Just to summarize the important points for the sake of audience, pre-operative assessment is very important. Do proper centering while estimating keratometry. Please rule out ocular surface diseases. And also, like particularly if the patient has undergone prior keratorefractive surgery in the form of RK, It was very important point stressed by Professor Tetyal that please suture the main wound, and hydration may cause slight deviation from the marked axis, and the rotation will help only if the spherical equivalent is more than the cylindrical error, otherwise it's not going to help. With that, I think we come to the next very important topic. Guest presentation is by Professor Boris Malyugin on virtual platform, and he's going to talk on cataract surgery in zonular weakness.
Yeah, good morning, Boris, and welcome to, I can say India, though it is, not physical, but you look quite, you can say ready for this presentation early in the morning in Moscow. I hope everything...
It's not as early, no, it's okay, it's fine.
Yeah,
thank you very much for your invitation. Really pleasure and honor.
Please share your presentation.
Okay. So I will be discussing the topic of cataract surgery in patients having zonular weakness. We know that zonular defects present significant challenges, and there are various scenarios for that. Here you can see some hereditary conditions predisposing to that, and these are some other conditions. So FACA goals will be to preserve capsular bag and prevent late bag IOL dislocation, which is obviously very important. For this type of surgery, very helpful devices are capsular tension rings and also capsular retractors of various designs. And first capsular retractor system was done by Rich McCall. And also there were anecdotic reports of utilizing pupil expander to capture the anterior capsulorhexis that may help in this type of surgery. Which is a bit challenging and not so easy to accomplish. So my favorite devices are definitely capsular retractors. So you can use them in triangular pattern, such as in this case, and I would like to demonstrate that case for you. Here is the patient with zonular weakness, and as you can see here, capsulorhexis already being done, and I'm utilizing now Mst Capsule Retractors. This is a Chang modification with slightly narrowed gap in between the two strands, and this modification allows you to avoid entrapping the CTR when you will be injecting it later on during the surgical procedure. So you can see that the device easily goes through 1 millimeter paracentesis, and then by adjusting the silicone sleeve, you're actually fixating the capsular bag. It's very important to note that these devices are causing not so much stress on the edge of the capsulorhexis, because they are supporting the equator of the capsular bag. However, in the area between two hooks, the capsule equator is not supported. And obviously you have to be careful and watch these areas to avoid aspiration of the capsule that can easily happen. So here I will be removing cortical material, and this is what I was just talking about this issue. You see, by aspirating the cortex, we can visualize the equator of the capsular bag, and simply because there is no support to the capsule in this area. So in these cases, when you see that the zonules are really weak, and you may consider implanting CTR a bit earlier before all cortical material will be removed from the capsular bag, and that will help you to support the whole circumference of the capsular bag, and will help you to finish that case without any other complication. So triangular pattern is having several advantages, such as reduced number of corneal incisions, less manipulations, and reduced surgery time. However, there is a bigger gap in between two hooks and higher chance for the equator of the capsular bag to prolapse and to be aspirated. So the other option is to have a square pattern, as shown here, when 4 hooks are implanted, and here is the location of the main incision, as shown on this. This pattern is having advantage of smaller gaps in between 2 hooks. However, you need more manipulations, longer surgery time because of increased number of corneal incision. So here is the option of utilizing iris hooks and capsule retractors, as shown here. 3 capsule retractors are implanted along with 4 iris hooks. However, my preferred combination is the Malugin ring and capsular retractors in Chang modification, and is shown here. It is quite easy to combine these 2 devices because you can expand the pupil and support the capsular bag simultaneously. So the advantage of this combination is opening the pupil and supporting the capsular bag. However, obviously you need additional manipulation and time, and of course increased costs because you need to use multiple devices at the same time, at the same surgery. So what will be the optimal capsular retractor pattern, whether it will be 3 or 4 square or triangular pattern? So it's still controversial. You can use both. So this is an option of the combination of 3 capsule retractors shown here, and instead of using 4th capsule retractor, I catch the proximal scroll of the Malugin ring and catch the anterior rhexis with the scroll. So you have a kind of combination advantage of having 3 capsule retractors, but also 4 points of fixation of the capsular bag. Here I will show you how it is being done. The ring is injected, and you can see that capsulotomy was already being performed in that particular case. Then the capsule retractors are inserted one by one in a triangular pattern manner. The 3rd one is now being introduced into the capsule, and the sleeve is adjusted. So as a next step, I will be using the proximal scroll of the device to catch the anterior capsule, and as you can see here, so this is a kind of combination support that was used here, helped me to protect the edge of the anterior capsulorhexis and avoid additional trauma, and also support the capsular bag. So here you can see the last steps of lens removal, and again in that case it will be a good idea to insert the CTR a little bit earlier. What about the IOL implantation? So my preferred method in severe zonular weakness is to use 3-piece IOL, as shown here, and the haptical elements of the 3-piece IOL will be positioned in the ciliary sulcus, and I'm now injecting this lens into the posterior chamber, and haptics are positioned in the ciliary sulcus. However, I will be using the second point of fixation, which is the optic capture. So in that case, lens is supported by the haptical elements positioned inside the ciliary sulcus, and the optic that is captured with the anterior capsular rexus. Prior to capturing the second portion of the optic, I aspirated some viscoelastic from behind the lens to avoid viscoelastic accumulation in the capsular bag, because we will not be able to remove and aspirate that as soon as the lens optic is fixated. Now I'm checking the position of the lens. So to conclude, I think with modern surgical devices, the safety of cataract surgery in patients with zonular weakness improved significantly. Capsule retractors combined with the Malugin ring and CTI is my personal preference in most of the cases. However, you may choose whatever you like. And finally, 3-piece IOL with haptic elements placed in the sulcus and optic captured with anterior rexus provide long and stable clinical outcomes. And I thank you very much for your kind attention.
Yeah. Professor Malugin, that was excellent presentation, and if I may say, we could really feel your presence here, sir.
Thank you.
Your presentation was so good, the transmission, and you could present your message so nicely and precisely within 10 minutes. So your choice is Malugin ring plus the capsular retractors plus CTR in patients with these zonular weaknesses. Is that so, sir?
Absolutely, absolutely. I think we need to have these devices in the OR for these type of patients. We know that when CTR is implanted a little bit earlier, before the cortex being evacuated, it complicates a little bit the process of extracting the residual cortical material. However, we can go for this type of implantation because we need to save this capsular bag and avoid equator aspiration. So it's a compromise. It's always a kind of compromise for the surgeon what to do first. But I believe in these cases it is justified.
Thank you. Dr. Malugin, like if you have a huge subluxation, especially huge zonular weakness, would you like to go in for the bag fixation kind of surgical steps?
I like to use the fixation of the bag with the specially designed CTRs, and I basically designed one of these based on the Sioni principle of the fixation element that goes from the bag through the capsular rexus. And I have a good experience with that. I like to use this technique in Marfan syndrome and congenital dislocations of the lens, and I believe it's very good. I recently switched because for many years I used for that purpose 90 polypropylene, but it really happened in several years postoperatively that polypropylene was broken. So in some of these cases I need to resuture this CTR. So now I'm using Gore-Tex, and 60 or 50 polypropylene with the flange technique might be another option to consider.
What about the segments, like use of segments in these zonular weakness instead of using CTR?
I think it's great. Frankly speaking, I don't have access to the segment, so I have access to the specifically designed CTRs only. But I've seen these devices being used in such a combination, and I think it's good. However, when we are talking about the generalized zonular weakness, so I think the CTR fixated to the sclera is better, because segment supports only part of the equator of the capsular bag. The other alternative is to use segment with the regular CTR, that may help to improve and to fixate the bag safely.
Yeah, because newer segments have the eyelets also in that, and you can, along with the bag fixation, you can do the bag suture of the bag also with the newer kind of segments in.
Absolutely, and when we talk about segments, we should also talk about Dr. Asia Ankor.
Yeah.
This is another option, segment-like option that help to fixate, to have a localized fixation of the capsule.
Yeah. Thank you, sir. Thank you very much, and for the excellent presentation. And now we'll go forward. And thank you very much for seeing you.
Thank you.
Thank you, sir.
Yeah,
Thank you.
being here
Thank
with
you.
us. Thank you.
Bye-bye.
So with that, we come to the end of the case presentations, and we begin with mini symposium, and the title is Current Practice in Ophthalmology. For that, I invite Professor J.S. Tityal, Professor Radhika Tandon, Professor Sudarshan Khokar, Professor Mandeep Bajaj, and Professor Rajpal Vora onto the dais, please.
Any announcement you want to do? Okay. Yeah. Thank you. We'd like to thank you, Dr. Rajendra Prasad, the Vice President of our society, and J.S. Ballaji for holding this session so nicely.
Picture worth 1,000 words. Yeah. It went very well. Yeah, very nice. Yeah. Did you get up? Okay. Thank you.
Very much.
So you are at the right place. Rajendra Prasad Center. Finally, there I had the
It's a very happy and great moment for me. Your own
yeah.
Yeah, sure.
दो बजाज कैसे हो गए? या दो बल्ले कैसे हो गए? मैं किसको दे हूँ?
Thank you.
शुरू करें? Yeah, good afternoon, friends. And after the initial presentations, which was I think it was nicely discussed. We had a lot of discussion on that, and icing on cake was Dr. Boris giving his presentation from Moscow. Now we're going to shift to our mini symposium, where we have included all the recent advances which can happen in a various super specialty parts of ophthalmic scenario. So first we're going to invite Professor Sudarshan Khokar. You all know he is one of the world leader in pediatric cataracts management, and he's going to give us the basic aspects of IOL consideration, which is so important in pediatric cataract surgery. Professor Sudarshan.
Right. Thank you, Professor Tityal, and residents, and of course colleagues. I think all of you must have touched me whenever we are doing the cataract surgery. You are calculating the power for me, putting the lens. We've seen the lens going upside down, single piece, 3 piece, go to the OR, change the power. Change the power on the table after doing a EUA. So I think it's a dynamic thing going on. It's not that you calculate the power like an adult in the OPD basis. Patient comes in, do the surgery, goes out, and that's it. Here, you might have to change the power at the 11th hour, because whatever excellence you've done outside might not be the same which you do on the table. So I'll be just talking about, I won't be showing any videos, I guess, because I'll be showing you the IOL considerations in these patients. So the question which is always asked, when should you implant? Whenever any forum I go to, they say, do you implant for people less than 2 years? Because there was a study by IATS in which they thought that if they put the lens in 14 months and younger kids in unilateral, their results were poor. But if you see the methodology of the study, it's totally haywire. Things are not taken into consideration, so I don't believe into the study. So most of the centers have started using implants even for less than 2 years, and we do it. So it's not which eye you should implant, you should know what is the health of the eye. If the axial length of the eye is anything 17, 18 or more, you can put an implant. The more important thing is the white to white of the eye. If it's 9 millimeter or above, you can actually put a lens in these ones. In fact, at the RP Center, we finished a thesis on which we did a UBM measurement of the eyes. We realized that all these, even the normal size white to whites and the excellence, the bag diameter is never beyond 10 mm. 9.5 is what we get. Majority of the patients are between 7.5 to 8.5. So these are small bags. So that means that you have to do a vitrectomy and open the posterior chamber, posterior capsule, then only these bigger adult lenses will go into these eyes, otherwise they not go in. Why do you want to do it? Because unilateral cataracts, unilateral aphakia is never a good option, and contact lenses our patient don't do very well. So implant has to be put in these eyes if the eye is healthy. So as they say, what is good for the goose is good for the gander. So if you can put it for the unilateral eyes, where most of the times the unilateral eyes are having a problem in itself. When you do investigation, unilateral cataracts, the problem lies inside the eye. So these are smaller eyes. You can have a PFBs, you can have PCDs. Where when you have a bilateral eyes, most of the times, maybe 99%, there's nothing you can get. It's a systemic problem which are causing the cataract, but the anatomy and dimensions of the eye are normal if you see that age for that respected age. And how is a technique I'll tell you, and which lens and material I think will cover up. So which power you want to put in? You can't use the adult power for the pediatric age group because it's not the adult eye, it's not a small adult eye, it's not a nanophthalmic eye. A nanophthalmic eye is a smaller eye in which otherwise eyes are healthy, but the dimensions are small. So these are not nanophthalmic eyes. So these are not even microphthalmic eyes because the size is not small, it's a curvature which is different. So there's a hyperopia in these patients, which people used to think there's no hyperopia as such. I'll just come to that a little later. So these eyes are going to grow. The excellence, which is 17 millimeter at the birth, by 2 years it will become about 24, 23. And the keratometry, which is steep to the power, say 52 diopters, will go down to 45, which is normal. So things are changing. So the excellence is increasing, the keratometry is flattening, so there's an emmetropization. So if the things go well in sync, you will not have a refractive error because all these things are actually getting traded off with each other. Okay. So if you want to put the lens straight away in the child, without any undercorrection, you might not have to use any plus number, and the patient might not have amblyopia. But once the myopia starts setting in, you can't control the myopia. They can go to 15, 16, 17, maybe minus 18, which become difficult to handle later on. Okay, so what you need to do is, okay, I think, so the growth of the eye actually takes place in 2 phases. First is in the first 6 months, 0.6 millimeters every month for the first 6 months. So that becomes 3.6 millimeter. That means 3.6 millimeter into diopters you convert, it becomes a huge shift. And similarly, the keratometry, you can see it's from the steep, it's going down. So these are from the studies. I think these are landmark studies. All of you know these studies before you start doing the pediatric cataracts. Okay, so this was a study by Gordon et al. In which they took all the patients which were born in the hospital, in the nursery. They took the consent and put the drop of cyclopelagic in these eyes and did the excellent keratometry and refraction for these patients. So they could find out what was the A constant. So all of you should know what is the A constant of the lens which is in your eye. Your crystal lens has a constant. So it comes to about 116 according to their study. What they found out was most of these patients were emmetropic. They were not hyperopic or myopic. But if the eye was smaller, if it's a premature baby, which Parijat looks at very often, so those are the patients in which it could be a little different. Otherwise, most of the patients were within normal refractive error. They were not highly hyperopic. So this I already told you, the growth which has happened. So what is happening to the axial length? Axial length will grow more if the patient, you operate early, IOL versus phakic. You leave the patient aphakic, the eye will grow more than what you anticipate because there's more blur at the back, right? If you're not using occlusion treatment in these patients, the eye will grow more. So most of the studies have said that. And if your patient by any chance has a glaucoma or increased pressure, these eye will definitely grow out of proportion. We've done some work with Vinay Gupta in which we did the IOL power calculation these eyes. We realized that you have to go very high under correction to the tune of maybe sometime 15 to 20 to 30% under correction because these eyes are going to grow over a period. And genetics, because depending on which cohort, which part of the patient, world you're seeing the patient, Caucasian eyes don't grow that fast. Indian eyes grow even slower than those patients. And Chinese eyes even grow slower than that. So that's what you have to see. So that's on basis of that we did a study in which we actually took patients in 4 groups, less than 6 months, 6 to 12. And all these groups, we followed them for 1 year now. And we realized what is the growth happening in these patients. So these were the patients with cataract. We did the IOL power calculation. So these were the lenses used for these patients. And then we did a reverse regression formula, and we realized that all these patients, how much undercorrection is required. So for the 5 years and above, there's no need for any undercorrection. 5 years, you need 2% undercorrection, and for 2 years, you do 5% undercorrection, and this works wonderfully well. So that means you're giving it a mild hyperopia for less than 2 years. Whereas the other formula, Prost and Dahans, they were giving 20% undercorrection for 10 years of age, for 5 years and above, which was very high. So 1 to 2 years, you do a 10% undercorrection, which is moderate hyperopia. 6 months to 1 year is 15%. And this one is in yellow because this is a high hyperopia. If the eye is good, 3 to 6 months, you're putting 20% undercorrection and we're getting good results. We follow this patient over a couple of years. We realize that by the time they're 2 years, they're almost where they should be actually. Less than 3 months are the one which are very high, grow very high. So in these patients, if you have bilateral cases, you can actually leave in the phakic there, leave a rim around it, and you can come back later on if you're not sure about your keratometry and excellence. And all these patients have to be done a proper examination and anesthesia. Measurements are most important. I can't stress more on that because that's the most important thing. So which lens to put? Okay, single piece is already used hydrophilic lenses. That's the best compatibility material. There's lots of studies on that. Initial group from Egypt used to put lots of philic lenses. Even Dr. Dihan, when I met him, he was still using philic lenses. But I think philic lenses have more problems. They can't cause a square edge well, and they can't push the posterior capsule to reduce the VOs, and they might get opaque on their own. I mean, that should be taken into consideration. Okay, so you put this one because that can fit into any of the sulcus, any size of sulcus. Your lens can actually mold and stay inside a single piece. Bagging the lens is not available to us, but if you can get the lenses, they can reduce the VO formation. I think I should skip down to, okay. And when you want to do a capture should be done for the patient in which there's either anterior capsule or posterior capsule not contiguous. If both capsules are contiguous, you've done it well, you can put a single piece into the bag. I think all the residents are all my SRs are doing a pretty good job. So whenever there's a doubt, your rexus, if it goes too big and your lens might come anterior, or there's one of the rexes which is not contiguous and it might extend, best is to put the lens in the sulcus, 3-piece, same power, and then you can capture it. So when you're doing the pediatric cataract, you have to have all the machine at your disposal. You need a good keratometry, you need a good excellent machine on the table, and if you can have a UBM, always add onto the flavor. And you decide there on the table what lens you want to give. So IOL gives the best rehabilitation, and you plan for the undercorrection depending on the age, which give you the formula, and always check the refraction IOP on the follow-up. So the best person will be the one in which the patient goes back to the same surgeon every 6 monthly. You do a refraction, do a keratometry, and you do excellent, and then you know what kind of patient you're getting and what is the growth in this group. So even in India, you see South Indian and North, there might be a little difference in the growth. And if the patient is using occlusion treatment or glasses, if they don't, then again the growth might change. So these all things have to be taken into consideration in all these patients. So what I'm trying to tell you is that if you take into the consideration all these things, you can always hit the bullseye. Now this guy is trying to hit without studying, so he misses the target. See, he's missed out the target. So if you take into consideration the fact, what is the pressure of the eye, what is the size of the eye, where you put the lens, whether the patient is using the glasses or not, and if you can take all that into consideration, you can always hit a bullseye. Okay, so it was not one bullet which hit the target. There were multiple of them. That means your power could vary from a plus 2 diopter to minus 2 diopter. Even if you're getting plus or minus 2 diopter with your IOL power, I think you're still hitting a bullseye because you can never be very accurate, as Dr. Titiala showed in the earlier. Your toric lenses are multifocal lenses. In an adult, where there's a sitting duck, you do the parameters and do the surgery, whereas these are dynamic eyes. So even if you have an error of plus minus 2, do not get disheartened. You're still doing a good job. Thank you very much. Any questions if you have, I can answer. Or you're not supposed to ask questions.
Okay, that was a wonderful talk, Dr. Khokar. The panelists, Professor Tushar and Professor Rajesh Sinha, their comments, if they want to add anything or share their experience.
Anybody else can ask a question? I mean,
yeah, or from the audience, if somebody wants to.
I'm sure Dr. Rajendra Prasad will have a question or two. He always have, yeah.
So you do UBM in all these cases?
I do in each eye, yeah.
This is to measure white to whites?
No. UBM, white to white you can measure on the top with the caliper. That's the best way of measuring it. UBM will help you the bag diameter. The bag diameter, and if there's a posterior capsule which is deficient, you can pick it up. This talk was not covering the UBM, otherwise I would have shown UBM finding. Otherwise, UBM is to tell me what are the things. Now, if I do a UBM, I can see things under the iris. So a patient with a persistent fetal vasculature, I can pick up the elongated ciliary processes behind the iris. right? So those you can pick up. You can pick up the anomalies at the angle. You can pick up the posterior openings very well in these patients, and you can measure the bag diameter. And you can find the volume of the bag also, whether if it collapses, you know, it's partially absorbed, otherwise it's intumescent. Yeah.
And which IOL formula, sir?
Okay, SRK2 is what we're using in these patients.
Not the newer generation, the Barrett, because
for the pediatric eyes, they don't work well. I think all the formulas have equal amount of errors. So SRK2 is the safest, that's what we use. But we don't stick to that because we undercorrect from that also. So we're not actually sticking to those formulas. So whatever formula we get will give you X power. Depending on the age, we reduce it further down. So otherwise, SRK2 with Inyadi's formula, which says that if the age of the patient plus the refractive error is 7, after all these studies for last 15-20 years, I think, I don't know whose brainchild was that formula works wonderfully well, Inyadi's formula. It's a very simple formula. If there's a patient 6 years, he should have 1 diopter for hyperopia. If it's 3 years old kid, he should have 4 diopter, and if it's 1 year, he should have 6. 6 diopter hyperopia means that your retinoscopy should be about 8 to 10, which normally will hit the target most of the time in these patients. Yeah.
Okay, so thank you, Dr. Coker. So before we start the next talk, we would like to invite the panelists, Dr. Praful, Dr. Nupur Gupta, and Dr. Sri Devi Nair on the dais, please, here on the stage. Yeah, thank you. Professor Vanati, please go ahead.
Thank you, sir. I think picking up on the lines after Professor Coker, talking about ocular morbidities affecting pediatric eyes, I will be talking on the role of intraoperative imaging in pediatric keratoplasties. No financial interest in the mention of any of the products during the course of my talk here. So pediatric keratoplasty now has evolved to an extent that the entire profile which is applicable to the adult eyes is now performed in pediatric eyes here. So how does intraoperative imaging change the way we approach pediatric keratoplasty? It has diagnostic applications. It helps in enhancing our preoperative considerations here and intraoperative considerations as well. It has a large role to play in custom component surgery in pediatric eyes, especially both anterior and posterior lamellar keratoplasties, and if time permits, I'll just touch on a few challenging scenarios as well here. So this is available for a more detailed reading here, and we will be updating this shortly for you, and you will be able to read more on the role of intraoperative perimetry in pediatric keratoplasty here. But one real good application of intraoperative imaging using your IOCT or the microscope integrated optical coherent tomography is that it really helps you to look at the wound configuration, the graft host junction configuration here, and this helps to avoid a posterior gape of your graft host junctions, which could be quite common when you're doing pediatric keratoplasties here. So a very nice configuration of the wound here is something which really helps your beginner surgeons or the novice surgeons who are adopting or starting to do pediatric keratoplasties here. But in recent times, when nomenclature for congenital corneal opacifications is undergoing a sea change, and when everything is coming under the umbrella of anterior segment developmental anomalies here, I think intraoperative OCT is having a huge role to play here, because most of these children, we know that we cannot examine them properly. So optimal preoperative examination is usually very difficult, and we'll have to do a preoperative examination under anesthesia, either at the time of surgery or before surgery, in order to evaluate the amount of corneal morbidity which needs to be dealt with when you're doing surgery in these eyes here. So this was one of the earlier papers here which talked about the role of IOCT in pediatric imaging, and one from our center as well, which did a comparative evaluation of comparing IOCT applications to other imaging modalities such as the UBM to clinical examination methods. And of course, IOCT really helps to enhance your intraoperative understanding so that you can do your surgical planning more effectively. Short of an IOCT, which has the disadvantage of poor access to everyone given its cost here, having a UBM intraoperatively really helps to decide on the amount of keratoiridolenticular adhesions here, and then will help to prognosticate these cases and will really help in counseling when you're talking to the parents of these children about the visual outcomes in these eyes here. So this is the use of an IOCT imaging here in a case of Peters anomaly, which now comes under the broad gamut of anterior segment developmental anomalies. Here you are seeing a keratoiridal adhesion with a slight touch of the lens in the center, and there is a lenticular opacity as well. So this really helps you to revise the ways or approaches which you would want to consider in managing these cases. Moving on to the role of lamellar keratoplasties here, I think the IOCT has a very good role in managing lamellar keratoplasties in our patients here, and as you can see, these are very profile or clinical presentations of congenital hereditary endothelial dystrophies here. And the patient which you are seeing out here, given that the corneal opacification is quite significant, that the pupillary details itself is not really visible well enough in this particular scenario here. So this is where an IOCT really helps here, and you probably need not have to do a penetrating keratoplasty here in such patients and take them on to do an endothelial keratoplasty here. This really helps you to visualize the positioning of the graft, helps you to really visualize if there are no remnants of the Descemet's membrane when you're performing the keratoplasty. So your Descemet's stripping is complete and optimal here. And the way you introduce your graft, the way the graft unfolds is also much easier in when you're using the IOCT here. Otherwise, you would have to revert to do a full thickness keratoplasty in such scenarios here, and we do know that the chances of graft rejection in this excellent prognosis condition, pediatric condition, goes down when you're doing a full thickness penetrating keratoplasty. So you have the IOCT here, the imaging of which really enables you to perform all the steps of a Descemet stripping of graft introduction, the unfolding, and also to see if the apposition of the graft is good as well here. I think in constraints of time, I will move on to the other indications here, and these are postoperative pictures of the same here where you can compare. One other scenario where the IOCT is really helpful in pediatric eyes, again in a scenario of CHED here, is you could have a higher quotient of retained Descemet's membrane here, even in the best of hands and even with the experienced hands here. So here you have the IOCT here, which really helps you to delineate this membrane here and helps to peel it off. Sometimes you see it on the very first postoperative day. It really breaks your heart to see a well done keratoplasty such as this with a retained Descemet's membrane, and you find a double chamber in such scenarios here. So having an IOCT here really helps to peel off this membrane with least damage to the endothelium here. Please remember that your slit lamp optics is much more advanced than what you have on your intraoperative imaging here, and an IOCT here giving a three-dimensional visualization really helps to delineate this membrane and take it out without any damage to the underlying endothelium here. So this patient now is a much older child and does retain a visual acuity of 612 and is seeing well enough here. Other scenarios are complicated scenarios as you do in post-slit or ocular surface reconstruction DALTs, and when your big bubble achievement in your anterior lamellar keratoplasty is not successful, then it really helps you to avoid inadvertent perforations as you're able to assess the thickness of the residual corneal bed as you're going deeper doing a manual lamellar dissection. I think one real wow effect using the intraoperative microscope is when you do big bubble DALT here, where you're able to assess your needle placement, the depth of needle placement. You could see the air cleaving the plane well, and you get a wonderful type 2 bubble here, as you can see here. And your deroofing, watch carefully here, you will see the Descemet's membrane falling back nicely when you deroof or remove the air bubble from the big bubble chamber here. So the brave slash done, and you can see the Descemet's membrane fall back very nicely here. So this is really useful for all beginner surgeons who are into corneal surgeries. That said and done, it does not mean that you really need to have your IOCT, but it's a very good teaching tool when you have residents to train and you are really able to show them and increase their understanding on how to do the particular surgery here. These are again post-operative pictures. One other scenario where an IOCT would be helpful is if you're doing endothelial procedures in patients who have undergone lamellar, filtering procedures here. ALTKs and hemi-automated lamellar keratoplasties are again other scenarios where the IOCT really helps. These are these are glue fixated grafts which we did in ALTK, using ALTK for a pediatric pediatric RBCD dystrophy here. Again, it involves an extensive teamwork here, and I do thank the chief faculty and the residents for the wonderful support that they afford. The anesthetic team here, our National Eye Bank, our particular senior residents who work a lot in taking care of the follow-up of all these patients, the pediatric ophthalmologists and the glaucoma faculty who extend extensive support in the outcome to achieve a good outcome in these patients here. I thank them all, and I thank you for your patient hearing. Thank you.
Thank you, Dr. Vanathi. That was a really lovely talk. Any questions? We can have 2 questions. We have some time. Dr. Bhalla? No? Okay, so the panelists want to react to this, please. Any add-ons?
Ma'am, since you have worked on that major review, which I think it probably came in 2006, and now you are working on this, any difference in outcome that you have noted over a period of time with use of this intraoperative technique?
I think we have, you are well aware that Praful, the number of papers talking about using IOCT in surgeries is quite limited. I think we just have about 6 or 7 centers who have reported their studies, one being from our center as well. And the reports of clinical outcome is much better in pediatric keratoplasty when you use IOCT in terms of looking at the deeper structures which are involved, and that helps in better planning. So yes, it definitely does surgically enhance one's performance if you have this tool in your armamentarium, and gives you better surgical outcomes, avoids post-operative interventions like you don't need to rebubble, or you would avoid an inadvertent perforation when you're doing a lamellar keratoplasties, deep lamellar keratoplasty. So definitely I think outcome-wise it does enhance your performance.
Thank you, ma'am.
Thank you, Dr. Vanathi. Now we can call upon the next speaker, and before that I can call the panelists, Dr. Lomi and Dr. Neelam. Can you please come up on the stage? And I feel honored to call the head of the ophthalmoplasty, Professor Bajaj, to give a talk on the latest in orbit surgery, and he's talking about the orbital concepts of. Anybody have a question? They can keep asking the questions. If you feel shy, you can write on a piece of paper and pass it on. And if you want name written there, it's fine. Otherwise, okay. So, Praful, I need 2 seats for the new panelists, please, guys. Okay, Dr. Bajaj, all yours, please.
Okay. Very good afternoon to all of you, and it's really nice to see such a good gathering with all our friends here from the DOS and our residents. So I'll be talking about this minimally invasive procedure for renal lymphatic malformations. As you know, this is a difficult area and very challenging area to deal with. And over the years, a lot of minimally invasive techniques have developed in oculoplasty, which have obviated the need for major surgeries. So slowly we've started believing that we can do some magic. So let's see what is the magic of this technique. So the malformations are either purely venous or purely lymphatic, and there is a spectrum. And they are all slow flow malformations. And these fall in the category of this. This is a typical venous malformations with its features. And then in the lymphatic malformations, you must have all seen nowadays more commonly they are veno-lymphatic. They're somewhere in between the venous and the lymphatic, and which were previously known as orbital lymphangiomas. The new term is orbital veno-lymphatic malformations. So these are the ones we are going to talk about. So basically, these fall into three categories: the macrocystic, the microcystic, and the mixed variety, depending on the size of the cysts that are present in the lesion. So here you see the imaging of a macrocystic lymphangioma with characteristic fluid levels seen on T2 weighted images. And this is an example of a microcystic lymphangioma where you cannot appreciate the cysts separately, distinctly, and it is all small cysts which are looking like one big mass there. So what are the treatment options that are available to us? Presently, these are the options which we do think about when we think of these lesions. And conventionally, surgery was the only option that we had, debulking of these, and we used to do large debulking surgeries where we were not able to debulk the entire lesion because of it is diffusely infiltrating the orbit. And then sometimes they used to bleed and have acute exasperations, which we used to give steroids for that. And now lately these sclerosing agents, a lot of sclerosing agents have been tried with variable success. And the gold standard is pisibelin, which is not easily available in our country and is fairly expensive. And the other substitute for that we have is bleomycin, which is easily available, quite economical, and we will see the results with that. So intralesional bleomycin therapy, it is used for these periorbital and adnexal lesions because they pose a therapeutic challenge due to their infiltrating nature, as I just said. And the surgical management is sometimes very risky because they are infiltrating around the optic nerve, and if we go posteriorly, there is a distinct chance of vision loss. And since this is a minimally invasive procedure, and because of this, like we just said, that the availability and the side effect profile is very good. I mean, there are hardly any side effects at the dose that we used for these lesions. So this is a very good option. So the mechanism of action bleomycin is summarized in this table, but basically the three main mechanisms are the apoptosis, the oxidative damage, and the obliteration of the vessels by fibrosis and thrombus formation. Now this is the procedure that we do here in our center, that intralesional bleomycin given at a concentration of 1 international unit per ml. It is diluted with the lignocaine and given with the 23 gauge needle. And in macrocystic variety, we just aspirate the contents first and give an amount equal to the volume aspirated. And in microcystic variety and other vascular lesions, we do the imaging. In the imaging, whatever is the largest pocket, we give a volume equal to that largest pocket of the lesion. And injections can be repeated at an interval of 6 to 8 weeks, and about 3 to 5 times, if depending on the response. This is the pre and the post intervention workup, where predominantly the main things are the volumetry and characterizing the type of lesion, the size, the site, and the type of lesion, and then grading the response according to the volume reduction that we have achieved. This video, excuse me, वीडियो चलाया था वहाँ पे अभी तो चल रहा था पहले. Okay, fine. Right. So this is a short video of the procedure that we have. We are using it under real-time ultrasound monitoring. So according to the site of the lesion, we just insert the lesion into the cyst, and then with a 23 gauge needle, and then negative pressure is applied after you reached the cavity of the cyst to aspirate the contents. And then of course you need to avoid going near the optic nerve, and the at least pupillary monitoring on the table is very important. And then without taking the needle out of that cavity, you just attach the syringe containing that bleomycin and then inject at the same site from where you have aspirated. So I'll just show you a few share with you the results of a few cases that were done. This case had a proptosis and huge lid swelling and this is the position after the injection. The imaging findings in this were showing classic fluid levels in this, and it was occupying the entire superior orbit. And post-injection, you can see that there is a dramatic change, and the cyst has quite reduced considerably in size and almost shriveled up. Another case where this is a young girl with this huge cyst causing, again, this findings which were similar to the first case. And you can see that after the injection, she's had a dramatic improvement in her clinical condition. These are the imaging findings of the same case. Again, you can see multiple cysts, macrocystic variety. The upper three pictures are the pre-injection and the lower three are the post-injection pictures. And there you can see very clearly that all the cysts have reduced dramatically in size, which has translated to the clinical improvement also. This is another case where this girl had this proptosis in the right eye with the fullness of the orbit, and you can see that she's near normal after her injection. Again, macrocystic variety on imaging with classic fluid levels, and in the post-injection, you can see that all the cysts have dramatically improved. This is another case. This was a girl who had lesions on her forehead also. So we ended up not only improving her orbital condition, but we also injected her forehead lesions, and they also were similar in nature and had a dramatic result in that. I'll just take one more minute, please. Sure. Again, another, that girl, I showed you case number 4, the imaging findings. And this case, he's a boy from Northeast. He had a fairly posterior lesion with a little upper displacement of the eye. And in this case, you can see that the lesion is extending into the posterior orbit as well as into the inferior orbit, and the post-injection is showing a dramatic change. This was our first case that we did in our series of starting bleomycin, and she also had a dramatic improvement. This is a case of a microcystic lymphangioma. You can see the small cysts are there, and in these cases you might get a dry tap. When you do a tap from a microcystic variety of lymphangioma, you will not get that fluid as you saw, or that blood-stained fluid which you saw, and you will get a dry tap. So you'll have to inject according to the volume of the cyst, volumetry done on imaging in these cases. Another case of microcystic lymphangioma, and this case also presented with significant proptosis, which has improved quite well after the injection. These are the imaging finding of the same case. You can see that they have almost totally disappeared. And this is the last case where he had a large cyst encroaching into the lower lid, and on imaging there was a dramatic classic fluid level, and which has now just disappeared. So these are some of the very few complications are there. The side effect profile is very good. These are the very few complications which are encountered, some which were all manageable, like conjunctival chemosis, skin discoloration which was transient, and subconjunctival hemorrhage in some cases. So to conclude that this is a paradigm change in the management of these lesions from massive debulkings and very intrusive surgeries into the orbit, which were very risky. And now bleomycin can be considered and is considered as a first-line management option. And you can always repeat the injections to titrate that with the response. And since it is a minimally invasive procedure, it obviates the need for a major surgical intervention. Thank you.
That was wonderful, Dr. Bajaj. So over to the panelists first. Dr. Neelam.
Thank you, sir, for showing such wonderful results. So maximum, how many injection you have given in, say, any case?
Well, maximum you're saying, yeah, maximum, usually the response comes in about 3 injections. They do not need more than 3. But in one or 2 cases, we did need to augment that with the 4th and the 5th injection. So about 5 injections is the maximum. But you should space them out. You should not give, like I said, about at least 4 to 6 weeks or 8 weeks if possible, because the response itself will take about 4 to 6 weeks to come. For the first injection that you were given, you won't be able to know the true response till about 6 weeks. So one is that you need to evaluate what was the actual response and then go ahead with that. And another caveat that I would like to add is that stray well away from the optic nerve, because in this series, luckily there were no side effects, but there are reports of optic nerve damage also. That can happen in 2 ways, that once you give a large amount of bleomycin on the table and then you put a pressure bandage or something on top without monitoring the response at that time, and you can have severe increase in the intraorbital pressure. And the second way is a direct toxicity onto the optic nerve. So for people who are going to start or planning to start or having these lesions in their clinical practice, I would say that start with the anterior lesions first, and even if there's a lesion which is extending back to the orbit into the posterior orbit, do not inject near the optic nerve, just inject in the anterior cysts, which will percolate down a little to the posterior ones also, but do not go directly down into the posterior part of the orbit.
So would you like to highlight role of a post-intervention steroids, oral?
Yes, that we were giving routinely, systemic steroids, which were started at a little higher dose in the first week and then tapered down over the next 3 to 4 weeks. So that is an important adjunct that is required, yeah, definitely.
So any question we can take from the audience?
Okay, so I think Dr. Bhalla is looking at the watch also. All right, so Dr. Bajaj, thank you very much, and thank you the panelists also. So let me call upon the panelists for the next talk. Dr. Vinay, can you please come up? And Tanuj, it's all yours. Tanuj is going to tell us about the latest in the glaucoma, what are we doing now. And
so hello everyone, today's talk is on a very new technology, courtesy of our retinal colleagues. We are doing now aqueous angiography in glaucoma management. So you will be aware that in recent times the glaucoma surgery has moved into the zone of minimally invasive glaucoma surgery, where you operate on the canal of Schlemm and either you inject implants into the trabecular meshwork or you cut through the trabecular meshwork. Now these are very expensive implants costing more than 1 lakh rupees, and if you see the studies done in literature, like this is one of the studies on the eye stent from Europe. 2 eye stents have been injected, and at 1 year the IOP reduction is only 8.7%. So patient has spent a lot of money, and that is a reason why there is a lot of investigation on why MIGS surgery is not having optimal outcome, and that may be related to the where you are operating in the area of the trabecular meshwork, and that is why aqueous angiography is now becoming important. So you are aware that the aqueous is produced from the ciliary body and then it exits through the trabecular meshwork into the collector channel, the aqueous veins and the epithelial veins. And in addition to the resistance in the trabecular meshwork, it is this outflow channel which is very important, especially for minimally invasive glaucoma surgeries. So aqueous angiography is a new technique where you inject tracers in the form of indocyanine green or sodium fluorescein into the anterior chamber, and then you image what is the aqueous outflow, and based on that you decide the surgery. So this is possible with a new flexible OCT system that we have in the operation theatre, and this is basically for retinal angiography, but we have been utilizing it for the aqueous angiography for glaucoma cases. You require preoperative preparation of the dye, which is indocyanine green and sodium fluorescein. Sodium fluorescein I do not recommend, it leads to a lot of staining. ICG has been previously used for staining of the anterior capsule. So this is done in conjunction with cataract surgery. So this is the procedure. You have to image the eye, and the current challenge is it's not integrated with a microscope. So while injecting the dye, the microscope is not available. So you inject the dye, and then this imaging system comes into play, the OCT, where you do a live imaging of the anterior segment. So once you inject the dye, you will see this quadrantic outflow. So it is not that the aqueous is equally flowing across 360 degree. You have specific areas of high flow, specific areas of low flow, and specific areas of no flow. And usually we have found that the nasal region is the one with the maximum aqueous outflow. So this is what happens when you inject the dye into the anterior segment, and you see now this is a normal patient. You can see 360 degree you have a aqueous outflow available. So the inference is that this patient is very suitable for an intracranicular stent because the outflow channels are very active and there is no obstruction 360 degree. Compare this with the next patient. You can see here we have injected the dye and the aqueous outflow is only functional in one particular quadrant. You can see rest of the area there is no aqueous outflow. So based on this, your surgery should be focused on this quadrant. If you operate on this quadrant where there is no flow, then even after injecting the implant or doing surgery, the surgery is going to fail. And in the next scenario, this is a patient with advanced glaucoma, and here after injecting the dye, there is absolutely no flow. So this patient is not at all a candidate for minimally invasive glaucoma surgery. You will have to do a trabectectomy or a glaucoma drainage device. So you can use guidance from aqueous angiography to select what type of surgery you want to use. And what we have done at RP Center is to develop a new technique of ICG aqueous angiography guided glaucoma surgery. So you first do the angiography and select the area where there is maximum aqueous outflow. You mark that area and then you strip the trabecular meshwork in that particular area under the gonioscopic guidance. You have marked the area of maximum aqueous outflow. So in that area the trabecular meshwork is removed. Rest of the trabecular meshwork is not dealt with. And then you do post angiography. You can see now pre-angiography, this was the flow, and you can see post intervention, there is a significant enhancement of the aqueous outflow. This was the first study published in world literature to show aqueous angiography guided ab interno trabecular surgery for open glaucoma. And this opens a new era in the imaging technologies for aqueous angiography and minimally invasive glaucoma surgeries, because you can guide the placement of the trabecular meshwork incision based on the area of maximum aqueous outflow. Some post-operative observation, it is basically safe to do this procedure prior to cataract surgery, because if you do it in pseudophakic cases with zonal weakness, the dye can stain the vitreous, and this is one of the very heavy stainings we got from Sorosine, so that is now no longer recommended. And this was one of the cases where you had a vitreoretinal staining, so we have stopped using it for pseudophakic cases, only for phakic cases. So just to summarize, aqueous angiography is a new tool for real-time imaging of aqueous adflow pathways to basically help you in decision making for minimally invasive glaucoma surgery on the trabecular meshwork. It can also help to guide you which eyes are suitable for canal surgery or you should go ahead with trabectectomy. It helps you to localize the best location for where to remove the trabecular meshwork, and also in the future it may allow a comparative evaluation of different MIGS techniques. The current drawbacks are it's an invasive procedure, so you do not do a subsequent follow-up because you have to inject it in the anterior chamber, and for pseudophakic cases of one with zonal weakness you can get vitreous staining. But in the future you are going to get non-invasive aqueous angiography, and that will really be the tool to test. And I wish to thank Dr. Anand, because this is very labor intensive, and I have put his additional qualification below. Thank you very much.
Thank you, Tanuj. That was a great one. Okay, Vinay, you want to add on something?
Basically, I think Dr. Tanuj, I think the jury is still not out whether we should put the mixed devices in the low flow areas or the high flow areas. So any comments regarding that?
So actually that is the current thesis we have given, that we are testing angiography and operating on both high zone versus low zone. So maybe after 6 months to 1 year I'll be able to give you that answer.
But it's very exciting, you know, to see that
yes, sir?
outflow channels. It's really exciting to see those, you know, outflow channels, and really it's very impressive. Definitely it's going to be a future direction to the, you know, all these glaucoma management. Wonderful thing, you know.
Thank you.
Anything, Devan, you want to say something?
Sure.
Okay, thank you, Dharmesh.
Thank you, Dharmesh. So let's call the last speaker, Dr. Rohit, last but not the least. And Swati, you as a panelist should come up. So let's see what we're going to talk about the myopic progression. Atom 1, atom 2, atom 3, and then the lamp studies. So I think Rohit's going to just tell us what is what and what should you believe and what you should not believe. And of course, you can have all these talks, Dr. Bhalla, for the DOS. You can always have these talks for the DOS. I think most of these guys will be there.
Thank you, Professor Tetial, Professor Coker, members on the dais, DOS for the opportunity. So I'll be talking about preventing progression in childhood myopia, a very unfortunately coming up epidemic in midst of this epidemic. Bulk of what I'm going to talk about is from this consensus meeting we had some time back, courtesy the AIOS, and some of the leading pediatric ophthalmologists from all over the country had come and we released these guidelines. This of course will be circulated by AIOS shortly, so I think all AIOS members will be getting this information. So essentially, why should we talk about this at the moment? The reason came out in about 2016, where we realized that the prevalence of myopia is increasing world over, and particularly in India. In fact, this work by the Brian Holden group showed that by 2050, as per their projections, 50% of the world's population would be myopic and would become the most common cause of irreversible blindness. We have done unfortunately that meta-analysis did not have much from India because Indian studies were very disjointed, but we tried to do a systematic review and we came out with again some very startling points. The crude overall prevalence over the last 4 decades was 7.5%, definitely higher in urban versus rural, and in fact the highest prevalence was in urban 11 to 15-year-old children, which was almost 15% in the last decade and increasing. The other cause for concern was the significant increase in the last decade among rural children, which is showing the urbanization of these centers and the fortunate or otherwise penetration of tabs, phones and internet into the rural hinterland. So unfortunately these facts are true, and we need to be aware and see how we can manage to prevent. So when would we want to intervene? The decision should be based on identification of risk factors, which we are now pretty much aware of: the baseline refractive error, the age of onset of myopia, parental refractive error essentially giving us the genetic component of myopia and its progression, and the visual environmental considerations. Whenever we decide or whenever we plan to intervene, the most important bottom line should be that you must document myopic progression. As of now, we have used 0.5 diopters increase in myopia per year as the watershed for deciding whether intervention is there or not, but again, depending upon the risk profile, depending upon the patient's interest, you may want to vary that, that plan, and of course the frequency of change of glasses. The risk factors for development and progression of myopia would be a pre-myope, which would be essentially a new category I'll go on to define now. We have been able to define a pre-myope as a child who has lower hyperopia than age-matched normal. So children who have lower hyperopia are more likely to go on to progress and develop myopia. Younger the onset of myopia and more rapid progression, which is particularly seen between 6 to 11 years of age. Parental history of myopia, and the risk is 3 times the general population or general child age if both parents are myopic, something which we are seeing fairly frequently in urban areas. Higher myopia or rapid progression becomes a major problem, that this child will go on to become a high myopic child with consequent retina and pathological changes. Females, for not so clear reasons, show a faster progression, and ethnicity, though Indians are more or less homogeneous in their ethnicity, we know that East Asians progress much faster than others. The environmental risk factor is the presence of the environment the child is growing in or studying in, and children who become myopic appear to spend much less time outdoors than their peers. Of course, the last 2 years have been absolutely tragic in this regard, and we know that there has been huge jump in the myopic progression in a lot of children who come to us. The amount of near work these children do, anomalies in binocular vision and accommodative lag. So esophoria and accommodative lag is clearly a factor that increases the progression. So identifying pre-myopes, low hyperopes, one or both parents are myopic, they spend less time outdoors, there is increased near activity including use of tabs, and binocular vision disorders like accommodative lags and high AC by ratios. Of course, right now we don't recommend interventions in pre-myopes, but you need to increase the awareness among parents, modify the risk factor. ARPOS has come out with the 20-20-20 rule that every 20 minutes take a 20 seconds break and look 20 feet into the distance so that the eyes get a chance to relax and the myopic stimulus decreases, and of course increase in outdoor activity. You need to communicate with the parents, assess the risk factors, and plan your management according to the risk factors. Parent education and patient education is probably the sheet anchor intervention that we can do, and we must inform them about the potential problems that myopia is associated with. The first cycloplegic refraction is a must. Autoref, take at least 3 readings, do a subjective refraction, prescribe spectacles based on the current refraction, do not undercorrect. There is no evidence that undercorrected glasses prevent the progression. Document the power of glasses and confirm the progression if you are planning to intervene. The other key intervention or assessment that we are now doing is axial length measurement by either biometry or ultrasound or optical biometer, because that's the key intervention we want to make, not just reducing refractive error progression, but reducing the rate at which the eye is elongating. Assess the binocular vision, particularly the presence of phorias. Ocular surface health, because you have alternatives like contact lenses which may be adversely affected, and pupillometry, because atropine may marginally though may increase the pupil size and the patient may complain of glare. The treatment strategy is based on the risk factors, economic status, and of course the compliance. We have spectacles and contact lenses as optical interventions. Monofocal contact lenses or spectacles have no effect. There is now something called a peripheral ad lenses. We know that the normal monofocal spectacle lenses create a peripheral hyperopic focus, which is a stimulus for elongation of the axial length, and therefore now we have specialized lenses like the defocus incorporated multiple segments that create a myopic focus in the periphery. They are emetropic for the center macular area, but they are myopic for the periphery, so that the hyperopic stimulus for elongation of the eye is not there. Again, accommodative lag is something that we have found in children who are rapid progressors of myopia, and you now provide them with bifocal prismatic ad lenses, which have shown in this group of patients to significantly reduce the progression of myopia. Soft multifocal contact lenses, in fact, were the first interventions approved by FDA for reducing the progression of myopia. Unfortunately, our patients are less acceptive. Again, for orthokeratology, again shown to be very, very effective, almost 45%, but acceptance among our patients is poor. Pharmacological, which is the sheet anchor, atropine, as Dr. Coker talked about, it was just by chance that they discovered that low dose atropine is as effective as 1% or 0.5%, and now there are multiple studies which have shown, including the Indian study, that low dose atropine works and is probably now considered the first line intervention. 0.01 is approved in India, and research is going on the effect of 0.05, and we need to match their side effects with the effect of the drug. And finally, the most important thing that we must advise in all patients is lifestyle modification, increased outdoor time, increase indoor ambient lighting, and frequent breaks. So these are key interventions which all children, I think, should be given. You need to decide based on the age. If he's a low myope, it may be just in a small child, may be part of emetropization. So don't just start atropine. Even in a high myope, document progression, because they may be just preterms who are having the residual high myopia that they have. Rate of progression, as I said, 0.5, ocular surface, binocular status, and environmental and genetic factors. We know that atropine maxes out at efficacy by 2 years, so consider tapering, but I didn't look for rebound. You taper and do not sudden stop. Contact lenses are useful, but somehow our experience with acceptance has not been so great. Combination therapy is now considered in children who are rapid progressors. So along with atropine, you can think of the spectacles, the special peripheral AD spectacles that are available, and in combination they have been shown to be very effective. You need to follow up these children and see the effect over 6 months and 1 year and actually document your reduction in the increase. And you need to stop or switch when progression is not controlled, when there is tolerance or visual side effects like patients on atropine can complain, and of course there are compliance and safety issues. This is just a table showing the relative effect of each of these interventions, and you can see that atropine and DIMS or the defocus spectacle lenses are among the most effective, but literature is coming in. So currently we are that you need to increase awareness about myopia and the next generation. What works is outdoor activity more than 2 hours a day, atropine drops, soft contact lenses, and ortho-K if the child accepts. Thank you very much, and this is the Singapore line: to keep myopia away, go outdoors and play. Thank you.
Thank you. So I think after this we'll be going out and having a food. Great. So before that, I think Swati, as a panelist, would you like to add anything to that? She's also working on the same project which Rohit is working on.
Thank you, sir, for that wonderful talk. I would like to say, because atropine is now kind of has established role in school myopia. What is your take on, because now people are kind of using it for other type of myopias also, pathological myopias or ROP-induced myopias. So is it advisable, or we still have to find out how it works on those cases?
Thank you, Dr. Swati. A question which I think is plaguing everybody. I would still say that document axial length progression related myopia. Unless you do that in any condition, it has no role to play. In ROP and preterms, it's more often the anterior segment that is responsible for the high myopia, so probably they're not going to be effective. But even in high myop, we are following a cohort of these different groups which are outside the conventional groups that have been evaluated in the study. We are seeing interesting results, but until it proves that they are effective in these conditions, it's difficult to say. But like I said, important to document that the progression of myopia is axial length related or not due to anything else, including keratoconus. So any child with high myopia cylinders, first rule out keratoconus or any other pathology before you start thinking of atropine drops.
Right.
Thank you very much.
Thank you,
all
sir.
of you. Thank you. Invite Dr. Balla to come up with the stage. In the meantime, on behalf of faculty of RP Center and resident doctors of RP Center, we would definitely like to thank you, all the DOS delegates who have come today for this monthly meeting. And we would also like to thank the AIMS administration for giving us access to this auditorium, and the other engineering staff which has helped us today, and our own staff of the center who have been part of this morning's function today. Thank you all of you, and Dr. Balla and Dr. Rajendra Prasad, please come. ग्रुप पिक्चर लेगा हो गया होगा तो बाद में No, we have something to be given. Don't just leave. Binocular है नेक्स्ट मजा आएगा जब आप एक्चुअल बन के आओगे. You have some more sessions.
I'll thank Professor Tityal for organizing such a wonderful DOS monthly clinical meeting, and on behalf of DOS we'd like to felicitate Professor Tityal for excellent combination of this virtual guest talk by Professor Boris Malyugin. I think this was a newer edition, and we have really a great attendance, and the talks were really excellent and very informative. Dr. Tityal, sir.
Now I'll be announcing the name of the persons who have got this earlier bird registration award. First is Dr. Bharat Mehta. Next is Dr. Prachi Grover. Dr. DJ Pandey. Dr. Om Prakash. Dr. Sabnam. Dr. Saurabh. Dr. N.K. Patnaik. ये है ओम प्रकाश. डॉक्टर अनिल तनवर. मेजर राय मेहता. डॉक्टर ज्ञान गोयल. डॉक्टर राजेंद्र प्रसाद. सॉरी सर. मेजर जनरल राय मेहता. जतिंदर सिंह भल्ला. डॉक्टर अरुण बवेजा. सॉरी सर.
मनोज राय मेहता.
डॉक्टर एस के वर्मा. डॉक्टर सतीश मेहता. डॉक्टर गौरव कुमार. डॉक्टर विपिन. डॉक्टर काजल. जोली रोहतगी मैम. तो देख कितने बच्चे हैं. डॉक्टर अंकुर सिंह. नहीं 20 तो हो गए. ठीक है 20 हो गए. और बताओ. डॉक्टर ओपी आनंद. डॉक्टर पंचमी. डॉक्टर बी एस सेठ. डॉक्टर सोनाली वर्मा. डॉक्टर अजय अरोरा. अनीता पांडा मैम.
I have 2 announcements to make. The next monthly meeting is going to be held at RML Hospital on 31st July, and we are going to have our annual DOS conference at Hotel Ashok from 7th to 9th October. Thank you, everyone.
Thank you everyone for participating in this program. I request all of you to join us for lunch, which will be on the first floor in front of the conference hall. Thank you.